Welcome to Fibroid Summit 2022. This is the second year of our research summit. We are so pleased to gather with you today to hear 5 esteemed presenters in fibroid and menstruation research. The Fibroid Foundation mission focuses on education, legislation, innovation, and research. As our organization has grown, we've developed a stronger footing in the research arena because we are all aware that the patient voice is critical. Without it, there is a huge void that halts our progress and leaves many questions unanswered. Fibroid Summit is an opportunity for both patients and clinicians to engage. In our audience today, there's a dynamic mix of patients and providers. As we listen to the presentations today, I hope that everyone will benefit from the information presented and the questions asked. I've had a goal of inviting thought leaders to unveil the most current fibroid research for quite some time. In 2020, our team began to plan the first Fibroid Summit. We thought about the research landscape and the need for more voices on the topic of uterine fibroids. We reached out to the Campion Fund to partner with us on Summit. We're so happy that Dr. Phyllis Leppert, president of the Campion Fund, accepted. Dr. Leppert has dedicated her professional career to the advancement of women's health. Dr. Leppert served as Chief of Reproductive Sciences Branch and Senior Staff Scientist, Reproductive Biology Medicine Branch at NIH. She also served as Professor of Obstetrics and Gynecology and Professor of Pathology at Duke University, where she currently serves as Emeritus Professor of Obstetrics and Gynecology. Dr. Leppert always offers thought-provoking insights that invite us all to explore unanswered questions in reproductive health. I hope that you all enjoy the Fibroid Summit, and at this time, I'd like to welcome Dr. Phyllis Leppert.
Hello. I'd like to welcome you to the Fibroid Summit 2022. It is such great pleasure to be able to co-partner this meeting with Soteria and the Fibroid Foundation. We're very excited about this program. We have put together some really great talks. We have 5 speakers. 3 are very experienced and well-known fibroid researchers, and 2 are relatively new to the field, and they will be presenting very provocative research. We're most excited about having this day with you. I'd also like to mention that the Campion Fund is devoted to fundamental research in reproductive sciences. We have been interested in uterine fibroids for a very long time. One of the things that's very interesting to me is that while 80% of women worldwide have fibroids, there has been very little research funding and research interest among the scientific field about uterine fibroids. We are devoted to changing that. So I would like now to introduce the first speaker to you. James Segars is going to be talking about major and treatment options for uterine fibroids. Jim Segars is professor of gynecology and obstetrics and director of the Division of Reproductive Sciences and Women's Health Research at Johns Hopkins University. He is a graduate of the Duke University School of Medicine and received his training in obstetrics and gynecology from Vanderbilt University. He was a physician scientist at the National Institutes of Health at the Eunice Shriver National Institute for Child Health and Human Development prior to going to Johns Hopkins. As an expert clinician, reproductive endocrinologist, clinical research and basic scientist, he has made major contributions to the study of uterine fibroids. He's published over 162 papers, and he has also written many book chapters on the topic. One of the things that he is known for is that he has shown that mechanical transduction is very important in uterine fibroid pathobiology. That means that small forces actually change the way fibroid cells behave. It is with great pleasure that I turn you to Dr. Jim Segars, who will present on current therapies and therapeutic options for uterine fibroids.
Thank you, Dr. Leppert, and welcome everyone to the Fibroid Summit. I'm Dr. James Segars, a professor at Johns Hopkins University, a reproductive endocrinologist, and a fibroid researcher. My presentation today will cover the impact of fibroids on women's health and review new effective medical treatments and minimally invasive treatment options. My talk is divided into 3 sections. The first section will answer the question, what is the impact of uterine fibroids on women's health? The second will cover available medical therapies and their effectiveness. And the third section will review minimally invasive options for treatment. So what is the impact of uterine fibroids on women's health? Well, the impact is immense because 70% of women will develop fibroids by the age of menopause. Roughly 1 in 3 women will seek treatment for the condition. While not all women with fibroids will seek treatment, many lives are affected. For listeners who may not know what fibroids are, they are benign tumors that arise in the uterus. This slide shows a uterus with fibroids that have been removed and cut in half. The arrows point to the tumors. As you can see, the rest of the uterine muscle is normal in appearance. Many fibroids are the size of the fibroid in the upper part of the photograph, which is labeled in blue. But fibroids may grow to be very large, as is the case with the lower fibroid. One uterus can contain multiple fibroids, and fibroids can cause pain, infertility, constipation, bulk symptoms such as frequent urination, or excessive bleeding. The bleeding can be so excessive that it leads to anemia and causes the patient to get a blood transfusion. The cause of fibroids is not entirely clear, but they do tend to run in families. One question I'm often asked by my patients is, how likely is the fibroid to enlarge? This slide shows the average growth rate of fibroids measured over time. As you can see by the red arrow, on average, fibroids grow about 6% in 6 months, but some grow faster and others actually shrink in size. Importantly, fibroids are a health disparity. The prevalence is increased up to 85% in African American women. Also, the disease occurs earlier in life. Myomectomies are 6 times more common in African American women as compared to whites. And hysterectomy is twice as common in African American as compared to whites. Also, the symptoms tend to be more severe, and the fibroid disease is more severe in African American women compared to whites, as they are much more likely to have multiple fibroid tumors. The racial differences for surgical removal of fibroids with preservation of the uterus, called a myomectomy, is shown on this slide. The rate of myomectomy in Black and white women is depicted by the lines. As you can see, the surgeries occurred earlier in life, and the rate of myomectomy is considerably increased in African American women, as shown by the red arrow, compared to white women. The diagnosis of fibroids can easily be obtained with an ultrasound. but there is a significant delay between the onset of symptoms and diagnosis. 1 in 3 women waited 5 years after the onset of severe symptoms before seeking a diagnosis. There are several reasons for the delay, and 2 common reasons were the lack of knowledge of what fibroids were and normalization of heavy menstrual bleeding. For example, because fibroids run in families, many women just assumed that it was normal to have very heavy bleeding because their mother had heavy bleeding, their sister has heavy bleeding, and their aunts had heavy menses. From the perspective of the society, the heavy burden of disease, coupled with the delay in diagnosis, led researchers to estimate the cost to be approximately $34.4 billion every year. For comparison, this slide shows the annual cost of cancers, which are about 1/3 that amount. More than the cost of the healthcare systems, fibroids greatly impact the care of individual women, as shown in this patient's story. The number of mattresses replaced, dozens. Tampon budget, a small fortune. Dates ruined, lost count. Not to mention 5 blood transfusions, 1 surgery, and 9 weeks of recovery. Having listened to the fibroid stories of our patients, we wanted to quantify the impact of fibroids on the lives of women. Our group conducted a review of over 3,500 reports and found 57 reports that provided sufficient data to address the question. Overall, fibroids were associated with poor quality of life, with physical, emotional, sexual, urinary, and defecatory problems. Interestingly, we found that women reported levels of disability that were similar to those in heart disease, diabetes, and breast cancer. Fibroids impacted social functioning and vitality, to our surprise, more than a diagnosis of breast cancer. While one might have expected older women to be more affected since fibroids grow as women age, actually the younger women had more problems. And these included unpredictable menses and anxiety associated with excessive blood loss. In fact, women considered quality of life as the major indicator of a successful fibroid treatment. So to summarize these findings, fibroids had as great an impact on women's health as did other diseases and conditions that were believed to be among the most impactful diseases of women. Importantly, many women do not want a hysterectomy. Years ago, surgery was considered the only available option, but that is not the case today. So what are the available medical treatments and how effective are they? Prior to 2020, the available options for fibroid treatments that were FDA approved in the United States were tranexamic acid, oral contraceptive pills, the levonorgestrel IUS, and Lupron. Tranexamic acid can greatly reduce the symptoms of bleeding, but it does not alter fibroid size or growth. Oral contraceptive pills and the levonorgestrel intrauterine system, or IUD, may reduce bleeding in some cases, but they do not affect the symptoms associated with fibroid bulk and size. Lupron reduces both bleeding and size, but is limited in duration because of bone loss. And of course, some women have very bothersome hot flushes. In the past 2 years, there are new medical treatments that women with fibroids should be aware of. These are Orellana and Myfembree. Both work by blocking a hormone called GnRH, and they work to reduce estrogen secretion at the level of the ovary. Both these two preparations have some estrogen in them to prevent bone loss and a low dose of progesterone to prevent endometrial growth. Both are effective. I'm showing here the data from Orellana. The height of the bar represents the percentage of women who had a reduction in heavy bleeding, which was 77%, as shown by the red arrow. Myfembree causes a nearly identical reduction in bleeding as shown here. Also, and importantly, both these treatments led to a significant reduction in fibroid size and an improvement in symptoms. That is, fibroid size was reduced 40 to 50% after a few months of treatment. And notably, both drugs are approved for up to 2 years of treatment. Currently, a longer treatment is not recommended because of concerns of bone loss. Now, some women do not want to take medical treatment for uterine fibroid symptoms. So what about other options that do not involve medication? Well, there are several minimally invasive options that do not require surgery or hysterectomy. In fact, there are so many options that it can be difficult for women with fibroids to know which they should choose and how well they work and whether they relieve symptoms or not. So to answer this question, our group performed a review of studies involving minimally invasive fibroid treatments. We evaluated 4,599 reports and found that 37 met criteria for the study. This manuscript is not published yet, but I'll review the data very briefly. This slide shows several of the minimally invasive options. We evaluated 6 different treatments, including uterine artery embolization, MRI-guided focused ultrasound, high-frequency ultrasound ablation, radiofrequency ablation, percutaneous microwave ablation, and ultrasound-guided sclerotherapy. This slide shows the results of 4 of the minimally invasive treatment options we assessed. These treatments were evaluated for times up to 2 years after the treatment was given. The higher the line on the left, the worse the symptoms. What we found was that there was no difference appreciably between the different treatment modalities. All were similarly effective in reducing fibroid symptoms. And further, these treatments appeared to be effective for up to 2 years. Dr. Spies will talk in greater detail about uterine artery embolization a little bit later in the summit, but the point here is that comparison of the treatments showed that all worked equally well. And you can see that if you look at the lines, they all trend down almost toward 0, meaning a significant reduction in symptoms, and in most cases by 6 months. In fact, that appeared to be the case for all of the treatment modalities we evaluated. This report is under review, as I mentioned, but the conclusion of the report is shown here. Minimally invasive approaches to fibroid treatment were equally effective to surgical interventions for improving the overall quality of life and reducing fibroid-associated symptoms. Furthermore, this information may allow patients and their providers to optimize the treatment modality and enhance patient-centered care. So to summarize the takeaway points from my talk. The impact of fibroids on health is considerable. Despite having a rapid and reliable test for the diagnosis and presence of uterine fibroids, there is a significant delay between the onset of symptoms, and the delay between the onset of symptoms and diagnosis can span years. Importantly, the severity of symptoms matches chronic diseases such as heart disease and diabetes. New medical treatments are available that can relieve symptoms in 70 to 80% of women, and these medications can be taken for up to 2 years. These new treatments not only cause a reduction in bleeding, but also lead to a reduction in fibroid size and an improvement in fibroid-related quality of life. Finally, women who do not want to take medication do not have to resort to major surgery. Minimally invasive treatment options provide substantial relief from fibroid-related symptoms, which last for years for most women. In conclusion, there are new effective options for treatment of women with uterine fibroids. I want to thank you very much for your attention and to the organizers for inviting me to speak today. And I'll end by showing some resources, and I'll be happy to answer any questions. Thank you again.
I've had the pleasure of working with Minerva Orellana, PhD candidate, for quite some time as she has researched the impact of uterine fibroids in communities of color. This is particularly important because that research is not abundant and we need it to be. Minerva is a first-generation college student and daughter of Salvadoran immigrants. She grew up in San Francisco and went to San Francisco State University, where she received her bachelor's in physiology and master's in cell and molecular biology. It was during her master's she became interested in studying health disparities work. She is currently a PhD candidate in the Clinical Translational Science track at the Mayo Graduate School of Biomedical Science. Her thesis work is looking at translational approach in uterine fibroids in women of African descent and women in the Latinx community. It is my absolute pleasure to now introduce Minerva Orellana.
So, hello everyone, my name is Minerva Orellana. I am a PhD candidate at the Mayo Clinic Graduate School of Biomedical Science. I'll be talking today about understanding uterine fibroids and menstrual health in Black women and Latinas using a community engagement research approach. I want to start off by saying I have no relevant disclosures. This slide is going to be an overview of what I'll be talking about today. I'll start with some background about myself, some previous literature and the study. I'm talking about the study itself, and then some of the results, and then our next steps. So this is starting with a little bit about me. I got my bachelor's in physiology and my master's in cell molecular biology from San Francisco State. And I was born and raised in San Francisco as well. And during my master's, I was looking at the stress response and how it gets under the skin. And then now I'm currently a third year PhD student at the Clinical Translational Science track at the Mayo Clinic Graduate School of Biomedical Science, where I started now focusing on community engaged research and health disparities work under both my mentors, Dr. Felicity Enders and Dr. Elizabeth Stewart, who was actually one of the speakers of last year's Fibroid Foundation. And my overall career goal is to become a community engagement research addressing health disparities, health inequities in underserved and marginalized populations. So starting with the topic that I'll be speaking of, I'll start with menstrual health. So menstrual health as described by Hennigan et al. 2021 is a state of complete physical, mental, and social well-being, and is merely not an absence of disease or infirmity in relation to the menstrual cycle. But in talking about menstrual health and menstruation is still a stigmatized experience despite being a natural occurrence. And there's a lot of community context that can create taboos and stigmas around menstruation. And most of the studies looking at menstruation have been done outside the US. And this is very important relating to uterine fibroids, given that one of the symptoms is abnormal uterine bleeding or abnormally long menstrual cycles. And Dr. Segars is doing a good intro of what are uterine fibroids, but I also want to mention that uterine fibroids has a high financial cost with women who are diagnosed. In 2010, the annual treatment cost in the United States was $34 billion. And this was 12 years ago, so you can only imagine how high it is today. And for women looking for surgical interventions, the cost can go from $6,720 to nearly $22,000. And this all depends on insurance coverage and if it's an inpatient versus outpatient procedure. So we see that there's these physical manifestations and this high financial cost to uterine fibroids, but there's also some psychosocial symptoms as well, with uterine fibroids resulting in feelings of helplessness, fear, and anxiety in some women, a decreased quality of life, and missing of work and social functions. One of the papers by Gaunt, 2015, called Beyond the Physical, talks about assessing symptomatic uterine fibroids on the emotional and psychosocial health of women. And here are some quotes that I've pulled out. When asked about how the uterine fibroids made her feel at the diagnosis, she talked about she felt tired and emotional and depressed. All of this has caused me to be depressed and it makes me feel inadequate. And this is just wearing me down right now. When a participant was asking about her quality of life, she said that it just makes me feel like there's nothing I could do about it. You know, something is taking over my body that I have no control. So we have all of this together, but there's also disparities in uterine fibroids, with Black women being diagnosed at a higher prevalence of 80%. Black women also have a 2 to 3 times higher incidence rate compared to non-Hispanic white women. And when Black women were diagnosed, they were also younger, had larger fibroid volumes, along with an increased number and more severe symptoms. And Black women were also 3 times more likely to be hospitalized and 7 times more likely to undergo myomectomies. And Black women are not the only ones that might be facing these disparities. But in a study done by Marsh in 2018, it was suggested that Hispanic Latinas may have greater symptom burden. And in a study done by 2008 by Hoffman also saw that Hispanic Latinas were 2 to 2.4 times more likely to have uterine fibroids compared to non-Hispanic white women. And some of the reasons for these disparities that these women might be facing might be some multi-level factors, including the historical underpinnings of racism in the healthcare system that have exacerbated the experiences of Black women concerning their sexual and reproductive health. Another aspect might be the perceived stigma around sexual health and negative feelings relating to their own healthcare experiences. And if clinical counters are perceived as biased or discriminatory, it could impede the trust in providers and timely access to care when women are seeking. So combining these all together, and along I'm going to be talking about some of the projects that I've been working on, it'll lead to why I'm focusing my dissertation on uterine fibroids in Black women and Hispanic Latinas. So the Going Far study has been done with one of my mentors, Dr. Megan Elise from the Mayo Clinic, and this was done in partnership with the Fibroid Foundation. And we recruited women through the Fibroid Foundation social media. We also did one-on-one interviews just asking about their uterine fibroid experiences. And we have been lucky enough to publish 3 papers on our findings. The first paper is looking at patient recommendations for shared decision-making in uterine fibroid treatment decisions. And this was written by Kristen Riggins. And this was done on the analysis of uterine fibroid diagnoses, the experiences with providers, patient evaluations of surgical treatment options, and care and treatment recommendations. One of the main findings was that participants were unaware of uterine fibroids before their diagnosis. So one of the participants said, I was confused. I didn't know what fibroids were. I was just confused about why. Then I kicked myself like, oh, I should have just come sooner to try to figure out what was going on because I was just allowed to live with it so long. Another finding in this paper is that many women looked for surgical interventions because there was a decline in their quality of life. One of our participants said, I'm in such pain, I can't walk. I have to work from home for work. I picked up a second job and I can't work that second job during the week because I can't stand for periods of time and I need to be close to a bathroom. For a better quality of life, I decided to pursue surgery. So this paper by Riggins, it shows that there needs to be more informed decisions between providers and patients when looking. The following paper is looking at, by Karen D'Souza, is looking at the experiences of women desiring pregnancy following uterine fibroid diagnosis. And this was an analysis of looking at the impact of uterine fibroids on fertility and reproduction. And most of these women, one of the findings was that most of these women recalled that their provider asking them if they had planned to have future children at the time of diagnosis. But the thing is that most of these women felt that this was a very cursory question. One of the participants in the study said, I guess vaguely she knows what my desires are, but there was not a plan to try to do what we can to make it so that's not so. There was no, okay, after this is done, if we want to try the IVF or do we not? There was none of that discussion. Another finding we found was that women who became pregnant reported complications of their pregnancy, with pain being the most commonly reported. One of the participants said, she's talking about the provider and went into detail about what I was going to experience, that there was a good possibility that I could experience fibroid degeneration while I was pregnant, and that the pain was going to be worse than labor, which it was. And this paper helped showing of how some discussions that need to be had while women are seeking for the treatment for treatment for their uterine fibroids, thinking about future goals in mind. The last paper is something that I was a lead author on, looking at the perceptions of ethnoracial factors in the management and treatment of uterine fibroids. And this was looking at the sub-analysis of the ethnoracial factors of all the women of this data set. One of the findings that we found is that a barrier to seeking care has been the perceived stigma and experiences in the healthcare system. One of the participants said, I take an approach, less intervention as possible, less interactions with the healthcare system as possible, because they don't have a great track record with women of color, which was something that was reiterated as one of the multi-level factors that we saw by causing these disparities in uterine fibroids. Another finding is that culture had an impact on perceiving abnormal menstrual symptoms. Yeah, one other person said, yeah, but I grew up in the Caribbean. So it was always drink tea, drink ginger beer, put a warm rag, take tablets, It was never something that they would say, oh, this is an issue, let's bring you to the doctor. So there's this cultural impact that we see relating to discussions about menstrual health that we now see with women who are diagnosed with uterine fibroids and we're looking for treatment. So bringing this all together, what we see with the taboo of talking about menstruation, the disparities and with multi-level factors impacting the disparities in uterine fibroids. And along with the literature, that's something I wanted to focus on my PhD dissertation. So combining this with this gap in knowledge that most of the research has focused on uterine fibroid experiences of Black women compared to non-Hispanic white women. There have been no focus on Hispanic Latinas with uterine fibroids, so they're very underrepresented in the literature. There has been no research on Black women and or Hispanic Latinas concerning menstrual health discussions. So we don't know what other discussions are being had about menstruation. And there are no studies looking at the impact of culture concerning uterine fibroids and menstrual health in Black women and Hispanic Latinas. So combining this all together, this set the foundation of what I wanted to look for during my PhD. And one of the first step was by trying to investigate the menstrual experiences and some treatments and barriers and facilitators in Black women and Latinas with and without uterine fibroids. And we decided to take a community engaged research approach. So we set up some virtual community engagement studio guides with a summit structure interview guide. And each of the studios had a range from 5 to 8 patient participants. Our first studio had women who identified as Black or African American diagnosed with uterine fibroids. And there's also the second studio had Hispanic Latinas without uterine fibroids. And here, this is the process of the community engagement studios, and it is a structured method for obtaining input from stakeholders to enhance the design, conduct, and dissemination of research. And our community engagement studios were done in partnership with Washington University, along with one of my mentors, Dr. Ballsbury, and her team who are pictured below. So each of the studios were held, and this was completely confidential. They also were held with a trained facilitator and 3 note takers for each of the studios. And then we analyze those notes with using traditional content analysis. And here are some of the questions that we asked during community engagement studios. We asked about 7 to 8 for each, but here are some select few. One of the questions were, how should we start conversations with women about their menstrual experience? Another one's, what questions should we be asking these women about their experiences based on conversations with their healthcare provider? And please describe how culture may play a role in treatment management of uterine fibroids in conversations concerning menstrual health. So I'll be talking about some of the results that we found. In our first community engagement studio with Black women, we had a total of 6 participants. Our second community engagement studio had a total of 7. They were held on March 13, 2021 and August 7, 2021. And we had a total of about 32 notes that we were able to analyze. Here are the demographics. The top, we showed that all the women in our Black women community engagement studio with uterine fibroids were biologically female and identified as female, with a mean age of 47.5 years. Our Hispanic Latinas, we were only able to get the demographics of 5 out of the 7 participants, but they were all biologically female and identified as female with a mean age of 39.2.
Hi, Minerva.
Hey, Soteria, how's it going?
It's going well. How are you? Thank you so much for joining us today.
Yeah, for sure. I'm
I
excited.
I've had the pleasure of working with you for quite some time, and
Yeah.
I thought it was super important to bring forth your research for many reasons, but primarily because when we talk about fibroids, we talk about the high incidences of uterine fibroids in women and menstruators of African descent, which is accurate. Um, and not but and I also firmly believe that that data is not comprehensive
Mhm.
due to the fact that all ethnic groups are not really studied
Yeah.
in terms of fibroid research. There's so much additional research that we really need to do, and I applaud you for really taking this on. So, what was your why in terms of this research? Can you expand on that a little?
Yeah, definitely. So when I first started here at Mayo, I was interested for sure in community engagement. As in, like in my training and my master's, I really want to focus on health disparities. And with my working with Dr. Balsbury, who helped me with the community engagement studios, we're kind of figure out where can I put my research, where can I put my interest in. And she connected me to Dr. Stewart, who spoke last year at Fibroid Summit, and she actually told me about uterine fibroids, and I was completely in shock because I didn't even know about uterine fibroids. I was one of the people that did not know that this had a really high prevalence, much more that there was this disparity in the literature as well. So that kind of piqued my interest. She was like giving me information. I did a literature review and I saw that there was not a lot of studies on women of color. And if there were, they were part of a bigger subset. And as a Latina myself, I felt like where are my Latina women who have suffered from the uterine fibroids as well? And luckily that there's a study, and at least it's starting by Erica Marsh, who's focusing exclusively on Latinas and trying to get the prevalence rate of uterine fibroids. So I kind of delve into that, but more on the community engagement aspect. So qualitative research and just asking about their lived experiences, because I think acknowledging how they're living their day to day is very important, and how uterine fibroids carries physically, mentally, and emotionally in these women. So that's how I started in this research.
That's very interesting, and I'm so glad that you did find the research compelling, or the need for
Yeah,
research compelling, because I view this as really filling in a much broader picture, and it further demonstrates the need for additional research funding in general for uterine fibroids, and it uncovers the huge voids that exist. So I'm looking forward to learning more about the research that you've done, and
yeah,
I appreciate you giving that great background on all of the references in terms of giving a historical perspective of the
yeah.
data that's presented to date. Um, we had a question was, why aren't Latinas included in the studies?
That I wish I could answer that question fully. I think so. One of the studies, and I cited it earlier, was looking at a study by Gaunt that's saying that there might be that Latinas have a higher symptom burden. The reason that that information was out there was because they finally had a high enough sample size of Latinas to be able to see something statistically significant.
Mhm,
In other studies, it's usually a subset of like a handful, so there's no power, like when you're looking at the information or the data,
mhm,
or there's just not enough, and they just mesh kind of like women of color as a cluster versus just individualizing by their ethno-racial identities. So that's why with my study, I want to focus exclusively on women who identify as Black and or African Latina, because we have to also include Afro Latinas in this, who identify as both. And I think with qualitative research, you could get their individual experiences versus something like surveys, who is a bigger population and might not hit that target. But that is something I'm thinking about improving, I think, in women's health as a whole, of getting their Latina voice in as a Latina and being a community member. I feel like we have been understudied in the literature in all aspects.
Yeah, I completely agree. And you brought up a fantastic point, which reminded me that oftentimes I remember some genetics research a few years back in uterine fibroids, and it was a study of women of European descent and women of African descent. And the only reason that the study didn't move forward was because there weren't enough participants of African descent. And that does not mean that there's not a need or a concern there. It just means that the data set was not able to be completed at that time. So I just wanted to bookmark that very important point that you made to let our audience know, our clinicians may be well aware of this occurrence in research and data, but our patients may not be aware that some of what they read or something that they refer to or rely on for information may not be comprehensive due to those just very basic, access and funding hurdles that we face in terms of fibroid research. So, someone asked a very good question. What is community engaged research?
I love this question. So community engagement research is, so as a researcher, there's what people call like helicopter research, that you go in and work with communities, well, work on communities, but not with communities. Within community engagement, we work back and forth with community members. So in the way I approach things is, and that's why we held the community engagement studio. I went to women who suffer from uterine fibroids or had the past diagnoses and tell them, what is something you wish we asked about or what we talked about? So not assume that we know what we want to look for, but have participants and stakeholders tell us what we should be asking, what should we be talking about. So it's like basically a relationship between community members and researchers to make sure we're answering the questions that are relevant to the community. And there's different ways of doing it. But it definitely involves partnership, which is what's Terry, why we've been working for so often with the foundation, because we want to make sure that what we're studying is relevant to community members and also to the research and the science. So we don't want to come in as researchers assuming things, but talking to members of what they want to know, what they want to hear, and being able to develop ideas and research questions about that.
That's so important, and it further demonstrates how important the patient voice is. I think
Mm-hmm.
your work and you putting a focus on community engagement is so precious to our community and many communities where advocacy is so desperately needed. And it strengthens the overall mission, I believe. So that was a great question from our community. Um, we have another. I know you shared some of the responses from patients when you asked them about their experience, but were there any other quotes or feedback that really stood out to you, or any surprises in some of
Um,
the feedback?
yeah, so we held those two studios. So one was with women who identify as Black with uterine fibroids, and another one was with Latinas, just no fibroids, but just asking questions about menstrual health and menstruation. And I think what really surprised me, and I think even me as a Latina, that there's such a big taboo just even talking about menstruation, and that actually impacts every, let's say, talking about gynecological disorder, not even uterine fibroids or endometriosis, that there's just this taboo about talking about menstruation and its connection to sex, that cultures don't feel comfortable talking about that. And there's like this hush hush about it, that then
Mhm.
um, women don't want to go to the doctor to talk about that because it's something that they weren't comfortable with. So I think that there's also this cultural religious aspect of it as well. And I think going to the root of not just uterine fibroids diagnoses, but even like just menstruation, because that could impact a lot of other gynecologists. So I think that was an impact in just hearing these voices. And one of the things that really stands out and being doing these studios and having these group of women talking about these experiences is that they know that they're not alone. You
Mhm.
know, and I think that's very, very important. And you could feel the camaraderie. They're like, yeah, no, and like see them nodding along in the Zoom, like I went through the exact same thing, and them feeling the support and just holding that community engagement study, which I found really impactful, and being able to watch as a researcher that you're connecting a community of people who didn't even know each other, but they're bonding over their shared experiences.
Mhm.
It's really impactful just seeing that and feeling that and knowing like, yes, this is important work. I got to keep doing it. It gives me courage and passion to keep moving it forward.
That is so beautifully said. And I think in a lot of communities, I know in my family, we didn't talk about fibroids. I never heard the word fibroid until I was diagnosed. And
Mhm.
I know that my mom, my grandmother, my aunts probably had fibroids, had hysterectomies from fibroids, but it was something that you did not discuss because it was viewed as shameful, or you just, suffered through the symptoms.
Yeah.
And I think much of what you raised is such an important topic to uncover because one, there's a huge emotional toll
Yeah.
when you're suffering with heavy menstrual bleeding or reproductive health concerns, and we're only just beginning to come to a place where we can have a discussion like we're having right now, and bring others into the conversation to make everyone feel comfortable expressing their symptoms and knowing that, like you said, they're not alone. That's one of the
Yes.
um, messages that we try to communicate. I would say probably most frequently when we receive outreach from our community is there's a concern that they're alone in this,
Hmm.
and this is not just the United States; it's worldwide.
Yeah.
And some communities are more. It's more of a devastating community and social impact if the person is ostracized
Yeah.
because of their diagnosis or inability to conceive at that time. And so I think that you know the research that you're doing is pivotal to opening up this conversation and understanding the dynamics in certain cultures and appreciating those dynamics because there's a historical component to
Yes.
some of these ways of living and the quality of life and how it's affected. And we have a question to kind of follow that. Someone asked, in terms of the taboo and the stigma, how can we fix it or change it or impact it? And how can we address it with our daughters? Because our younger
Yeah.
generation is watching us and they're looking for guidance. And in your research, did you um, come across anyone who discussed the younger generations or in terms of the Hispanic Latinas
Yeah.
specifically?
Yeah. So I'm not a menstrual health expert. I'm trying to be. I'm developing into that. So I'll try to the best of my ability. But something I did see brought up that there's this generational bias. So what I saw within generations or women that were in our communication studio based on their age, they were responding differently to the questions of menstruation. And those who were younger were more vocal about their menstruation experience or even their uterine fibroid experiences and spreading the word along like this happened. You should be aware that this is a thing. And how we should better educate them. I think it could start at home. And what's happening is that there's a normalization of these menstrual experiences and menstruation as a whole that we should be doing. So I'm like, if it's heavy bleeding, what is heavy bleeding? We should probably read up to see what's something that we should be checking out and having conversations with your daughters or your nieces. I'm like, how's it going? Like, because it is an experience that women every month typically. So it's something we're gonna have for like the rest of our lives that we should probably be comfortable talking about. Whether it should be, I think it should start at home personally. I believe that. But I know there's also aspects that some families believe that the education starts at the school level. And I think, no, from what I remember in my growing up, there was conversations about that in school. And I think that's something that will be starting moving to implementation science after my thesis is done. So what are the next steps after this? How should we educate women? And hopefully we're finding those results out in the one-on-one interviews I'm hoping to conduct and move that next forward because I think that's a very aspect. Where do we start educating? And then we can move, should we be set at home? And how do we do that? Should we set in schools? How should we do that? So that is actually one of the next steps that we're thinking about, or at least me in my future career as a scientist. Like, how should we be educating these women? Firsthand, but I think what you could do now is just having those conversations with your daughters before they start menstruating, because you're like, no, they're too soon. But the age of menstruation is getting lower in the United States. So I think having the conversation sooner. If you menstruate, normalize your daughter. I'm like, this is a pad, a tampon, whichever menstrual product that you use, and make it seem normal and natural because it is a natural occurrence. So I think normalizing that and not normalizing what's heavy symptoms, heavy burdens that we're not getting this checked out.
I couldn't agree more. And in terms of research studies and being able to contribute to studies like yours, someone asked the question, what are the biggest barriers to comprehensive research? And as a patient, how can they change that or help that?
That's a good question. I think I think now, given the age of the pandemic, studies have become a lot more manageable. Like, let's say with the community engagement studio, they used to be done in person, but I was able to hold mine via Zoom across different zip codes and states. So it made it easier and more manageable. With my qualitative interviews that I'll be conducting, I will be doing this via phone. So location is not really a matter. We could find things like that. And I think that's a blessing about community engagement or doing interviews or qualitative research. You're not need to physically be there to participate them. Other studies might require you to be there in person. But I know I'm trying to like we're going to recruit it through the Fibroid Foundation, so our study will be announced on the social media pages and that, so you can participate. That I think studies who do community engagement work with foundations, organizations, and I think if you keep an eye out, you'll be able to better participate like that. I know at Mayo Clinic we have a page full of studies that people could participate in if they want to contribute to the research. So I think it's a search and a find. I wish it could be more accessible, but I think finding like what you're interested in looking at and be able to look at like studies, I think would be easier to help participate.
You actually answered one of the questions, which was how do you see the future of your research progressing? So your psychic powers are working there. You answered that. And I'm excited to see what your next phase of research will uncover. And I appreciate you taking that on because I think that you're well suited to do so, not because of ethnicity, but because of your just, I've seen you really dive into research. And I think your background is so well suited and your natural curiosity, and I particularly appreciate the way that you framed a lot of the studies and the way that you've presented them is very engaging, and I think is going to really uncover a lot. Um, Someone asked, did you, when you interviewed the participants, did you notice any patterns or trends in their preferences around fibroid treatments, either hysterectomy or myomectomy? Was that something that they vocalized?
Um, I didn't see any specific trends. It was a small sample size to actually come with trends. The women that we did do for the that studio were older, so most of them already were like postmenopausal or were done having kids. So for them, easier access was to do a hysterectomy because they weren't thinking about children anymore at that time. For the ones who were younger, we're looking for more, I guess you could say, methods to have maintained childbearing. So that's some of the trends that I did see, I think, in another study that I participated, not in with uterine fibroids, but with endometriosis, I think the same things were found. So women who were of younger childbearing years would prefer more conservative treatments versus hysterectomy. So those are some of the things that we saw, but we did see an exploration of other methods of, food, diet, birth control before going to surgical treatment. But if it was a lot of pain that a woman was dealing with, they do think about doing more like surgeries to overcome that because it does impact their day to day and they're thinking about their quality of life. And that was very important to them.
That's really insightful. What resources do you think might be beneficial to help with communicating around the research and the research that will continue after today? Communicating with the community specifically, are there any Spanish language resources or any ways that we as advocates can be better, improve our communication with the community?
I wish I knew how to answer about the resources, but I think from what I've seen, and I haven't looked to see if there's something there, but I think consolidating all the treatment options that are available for uterine fibroids. I think for participants who are diagnosed with uterine fibroids, I think having a checklist of everything that they participate in. My alarm's going off. Let me. All right. I think just consolidating the treatments that they've done and keeping note of all their medications that they've done, and when they go to their healthcare providers, having that list handy. But I think if there's somewhere that we could just put all the options available would be really helpful. And it just having a one-stop shop to look
Mhm.
at what's being done and what's being needed, I think that would be really helpful.
I agree. And my last question is really more of a comment because I was really intrigued by you mentioning Dr. Marsh's study and that the disparities are the burden in Latinas may be as significant as women of African descent. And I think that's a great topic to kind of close on because it really emphasizes the need for your research and additional research funding to make sure that we have a full picture of how
Mhm.
all women and menstruators are affected by uterine fibroids because the community is millions of people. And
Yes,
uh,
yes.
I've always mentioned that the research dollars really need to be representative of the
Mhm,
community and the
mhm.
communities impacted. So,
Yeah.
Minerva, I wish you much continued success with your upcoming presentations at conferences. And it's been such a pleasure to work with you. And I really appreciate you participating in Fibroid Summit this year.
No, thank you so much, Sarah. I'm happy to be here and share the information and the research and our continued partnership. I love this a lot and this research being done.
So, thank you. Hello again. We were pretty far along in our planning process for Fibroid Summit 2022 when I met Dr. Kevin Hellman. When he shared his research with our team, I knew immediately that I wanted him to present this year, and you will see why in just a moment. Dr. Hellman has been studying period pain for over a decade. His laboratory has developed novel diagnostic methods and conducted treatment studies. Dr. Hellman's goal is to systematically define the pathophysiology of dysmenorrhea and develop new treatments while simultaneously training a cadre of future investigators to revolutionize the study of visceral pain. This research is essential because there are few other laboratories dedicated to eradicating dysmenorrhea, one of the most frequent causes of suffering and gender disparity worldwide. It is my pleasure to now introduce Dr. Kevin Hellman.
Good day. My name is Kevin Hellman. I am a scientist at Northshore University Health System, and I'm a research associate professor at the University of Chicago. I've been studying menstrual pain for over a decade, and I'd like to discuss also why there's overlap between menstrual pain and fibroids. And when it comes to menstrual pain, I can speak a lot to of the science of why it hurts, and with better understanding of why it hurts, I hope it can help some of you and help others that are doing research make it hurt less. To some extent, if we understand what causes menstrual pain and the overlap of fibroids and the science behind it, it could lead to better treatments and certainly ideas of our current treatments, how to make them work better. This work is entirely funded by the NIH. I have no financial conflicts of interest to report. Our lab currently has 8 members, and we are funded by the NICHD. And because menstrual pain overlaps with bladder pain and irritable bowel syndrome, we're also funded by the NIDDK as well. So most women have menstrual pain, and there's a study by Solomon et al. That reports that over 60% of women with fibroids also have menstrual pain and have bloating pain. So what is dysmenorrhea? Dysmenorrhea is pain on periods. Some people actually have their pain just before their period. It continues during their period. Some people just have it before. Some people have it just during their period. The most commonly utilized medication for menstrual pain are NSAIDs, non-steroidal anti-inflammatory drugs, and an example is ibuprofen or naproxen. Those are over-the-counter medications. And they don't help everybody. So we can divide menstrual pain or dysmenorrhea into two types. There's primary dysmenorrhea, where there's no clear anatomical cause, and secondary dysmenorrhea. So fibroids or leiomyoma is a type of secondary dysmenorrhea. There is an anatomically plausible mechanism or something clearly wrong in the uterine anatomy that could be responsible for their pain. We have noted in our own research that people with primary dysmenorrhea, if they take naproxen, about 90 minutes later, they'll have a 50% reduction in pain with naproxen or any other NSAID. People with secondary dysmenorrhea, so that comprises people that also have fibroids, they do not get as much of reduction in pain with NSAIDs. So fibroids are associated with less improvement with over-the-counter medications. And in our own cohort, this is a smaller cohort here, women with secondary dysmenorrhea miss on average 2 days of school or work per month. So that's pretty severe. We've specifically looked at our larger data set. This is unpublished data, and we've studied or accumulated data from 33 women that do have fibroids. On average, they rate their menstrual pain as 7 on a 0 through 10 pain scale on their worst day of period pain. So 0 is no pain, 10 is worst pain imaginable. 7 is quite a lot of pain. And what's even worse is it's not just their periods. 1 out of every 3 of these women has pain that persists outside of their period. Our lab has shown that people with menstrual pain are 13 times more likely to have other pelvic pains, even outside of their period, such as bladder pain, pain during urination, pain during a bowel movement, dyspareunia, that's pain with sex, abdominal pain, pelvic pain, even overall pain. So what you see on this bar graph are 5 different groups of people. People without any period pain at all, people with mild pain, people with moderate in green, severe and very severe. And you can see as people's menstrual pain gets worse, they're more likely to have worse pelvic pain. And this is a cohort of over 1,000 people. So this is a very serious problem. We hypothesize that the repeated episodes of menstrual pain results in cross-organ sensitization and worse other pelvic pains. So menstrual pain is something worth addressing, potentially to reduce the risk of other pelvic pain conditions. So in order to better understand menstrual pain, we've developed a special method where we ask people on their period to come to our site, and we scan them with an MRI machine. They are in the scanner for about an hour, and while they're scanning, we give them a squeeze bulb like this, and they're asked to squeeze the bulb every time they have a cramp. So in people that don't have menstrual pain, they have peristalsis, and what you're seeing here is a video of peristalsis. So there is movement of the endometrial layer and some small movement of the myometrial layer, but it happens very rapidly. It happens 5 to 15 times over a 15-minute period. And we see that in healthy controls or people without menstrual pain, regardless of where they are in their cycle. And certainly we see that in people with menstrual pain as well. And so this is a 10-minute epoch from this 2D slice. And what you can see, it's easier to see when it's colorized, are these episodes over here of peristalsis. So this is uterine movement. This is probably healthy. It might be even essential for reproductive function. It's important to point this out because uterine activity is normal and it's healthy. But what we see in people with menstrual pain is something a lot more severe and much more intense. And what I have here is a raw MRI image, and I've colorized it to make it easier to see. And I'd like you to pay attention to right over here. This is the myometrial layer. So it becomes very dark, so there's a change in the signal intensity in the anatomy, and the endometrial cavity contracts. This event lasts as long as 40 seconds. This sustained uterine event is probably a uterine contraction. So we only see these uterine contractions in people with menstrual pain, and we typically only see it on their period. Not everyone with menstrual pain has uterine contractions, but we only see these kinds of contractions in people with menstrual pain. And what you see here is a participant with a fibroid, very large fibroid, and this is the uterus over here, and this is a 10-minute segment of time from this participant. What you see here, there's very little activity in the fibroid, but this participant has these 1-minute long contractions. And this is the average signal intensity, so you can see the contractions better. And the participant squeezes a pressure bulb at the beginning of this contraction. Here it's towards the middle. And not every contraction is associated with a cramping event. But essentially, it's important to note nothing is occurring in the fibroid. What is occurring is there are these sustained uterine contractions that are exclusively within the uterus. So what we think is occurring is the high pressure from the uterine contractions are causing pain, and it may not necessarily be the fibroid itself. This is an example of a participant without pain, and you can see absolutely nothing is occurring during this 10-minute period of time.
If you copy an existing note written like this, will the data service update?
So this is, again, an average across many participants. This is the change in signal intensity. So we see some participants that have a lot of cramping right at the beginning of this uterine contractile event. Some participants have pain at the beginning and towards the end, and some participants only have it towards the end. So we think this might be some mechanical sensitivity to the initial pressure, and this delayed pain could be due to either ischemia, reperfusion, or a blood clot passing through the cervix. So we've also looked to see what happens when we give people NSAIDs, what happens to their MRI activity. And it's worth noting what these over-the-counter medications do. So here is a whole bunch of them. Acetaminophen, also known as Tylenol. This is not an NSAID, but it can help, at least initially, with menstrual pain. Ibuprofen is an NSAID, and naproxen at 2 different dosages. And you can see naproxen at the higher dosage works a lot better than the lower dosage. So this is the equivalent of the 2 pills over the over-the-counter dose. And you can see already at 2 hours, you get a lot of analgesic effect. So this is the medication we use in our research. And this is not just an example of contractile activity. We looked at oxygenation using bold MRI imaging. And what you see is a healthy participant before and after naproxen. And this is just the raw image, and this is the colorized image, the bold image that colorizes the relative level of oxygenation and perfusion. And this is a participant with menstrual pain. What you can see is before naproxen, we have these hypoxemic events. So there's decreases in oxygenation. It occurs 5 times over a 10-minute period. And then after naproxen, this participant responds to naproxen. These contractions or contractile events or these dips in oxygenation completely disappear. So we think to some extent naproxen might act by eliminating the inflammatory molecules that produce these contractile events. However, it's not just contractions that produce menstrual pain, because not all of our participants have contractions, and sometimes the level of the contractions does not match the level of menstrual pain. So one other possibility is these women may have a gastroenterological cause for their menstrual pain. Dysmenorrhea often overlaps with irritable bowel syndrome. And what you see is a form of imaging that's very sensitive to the level of bowel gas. And these white pockets here are pockets of bowel gas within the intestinal tract, within the large intestines. So this participant has quite a bit of bowel gas compared to this participant on the right. So many of the diets that help with irritable bowel syndrome also help with menstrual pain. So this is not a test that's routinely available to identify whether a person has bowel gas or it's contributing to their menstrual pain. But one of the things that should be considered, because there's such high overlap between menstrual pain and irritable bowel syndrome, that if there are gastroenterological symptoms, a person should have their irritable bowel syndrome treated. Another potential mechanism that's responsible for menstrual pain that we noticed in our research is that people have large abdominal muscle contractions. And these large abdominal muscle contractions, this is not the uterus, this is the abdominal muscle. They often precede the report of pain. So what we think occurs is that there is a uterine contraction which results in a reflex abdominal muscle activity. And what you see down here is report of pain from a participant, and this is an abdominal muscle recording. You can see that the abdominal muscle activity precedes the report of pain for nearly a second. So this is known as referred pain. It's not coming from the organ, it's coming from the abdominal muscle. And we can look at abdominal muscle activity over time. This is a couple of minutes, and you can see that very often these abdominal muscle events precede pain, and it continues to get worse and worse and worse. So imagine doing a sit-up every couple of minutes. Well, if you're doing that every couple of minutes for days, it could become extremely painful. So we think these repetitive abdominal muscle events are likely aversive. So it's not just the uterus, it's a skeletal muscle reflex. And that's why the abdominal muscle can also hurt as well. So that might be another area requiring treatment or consideration when it comes to menstrual pain or menstrual pain with fibroids. Finally, why don't NSAIDs always work? So our group looked to see whether naproxen, one of the more commonly used over-the-counter medications, was absorbed. If it's not absorbed, it's never going to get to the uterus. So we also looked to see how much pain relief people are getting. So we looked at people that have primary dysmenorrhea and people that have second dysmenorrhea. And as I noted before, people with secondary dysmenorrhea, many of them also have fibroids. And what you can see over here is some people had very little analgesic effectiveness. Basically, they had no reduction or very little reduction in their pain. And there are some people out here that had almost complete analgesic effectiveness. And generally speaking, the higher their analgesic effectiveness, the higher level of naproxen was found in their blood serum. So the more naproxen that was absorbed, the more likely they were to have analgesic effectiveness. Some of our participants absorbed very little naproxen. That means that people are taking these over-the-counter medications. They're not being absorbed, and they're not being very helpful as a result. And this can happen in people with primary or secondary dysmenorrhea. So besides the anatomical contributing factor of having a fibroid, one reason why people with menstrual pain may not be responding to NSAIDs is they're not absorbing their medication. Another thing that we have published on is that people with menstrual pain have higher blood pressure, have higher sympathetic to parasympathetic balance, even when they're not on their period. So there's something about menstrual pain that results in long-term, persistent autonomic dysfunction, and that can result in impaired organ control. It can result in exacerbation of other pain issues, and there's been a lot of literature that links autonomic function to pain modulation. So to summarize the mechanisms that I've discussed that might be responsible for menstrual pain as well as their treatments, I showed evidence for a role of uterine contractions, and I showed that NSAIDs can get rid of these uterine contractions. Unfortunately, NSAIDs are not always completely absorbed. There are toxicological assays that can be used to see if NSAIDs are absorbed, but these are not commonly used. So if an over-the-counter medication is not working for you, you're going to have to see a physician for some additional guidance. Bowel-related pain could also be another cause of menstrual pain or its exacerbation, and it's important to know that there are special diets that involve decreasing the level of fermentable food, which will result in less bowel gas. This is a standard treatment for irritable bowel syndrome. Notably, it's been shown that if you treat irritable bowel syndrome, it will help with menstrual pain. And conversely, if you treat the menstrual pain, it will also help with irritable bowel syndrome. So this is a concern worth evaluating. An OB-GYN or a gastroenterologist can help with these concerns. The other thing I discussed was referred pain. So referred pain is possibly caused by these abdominal muscle contractions. Of course, a hot water bottle or a heating pad may help with this abdominal pain, but there are transcutaneous electrical nerve stimulation devices that are available over the counter. You can buy them at pharmacies. These electrical stimulators, you put these electrodes on the abdomen, and they can help with abdominal pain. There have been numerous studies that have shown that this helps with menstrual as well as other pelvic pains. Finally, I mentioned autonomic dysfunction, and there's many ways of addressing autonomic dysfunction. There are psychological and alternative and complementary strategies such as mindfulness, progressive relaxation. All these, if they're successfully used, can help with menstrual pain to an extent. If people were to use all of these strategies and consider using an OB-GYN that specializes in pain, because there are very specific treatments for pain, and there are OB-GYNs that specialize in pain management. And finally, I'd like to urge people to consider participating in research. There's very few labs that study menstrual pain, and it is absolutely essential for us, in order to develop better treatments, to better understand the mechanisms responsible for menstrual pain. So participating in research, supporting research. The NIH is one of the largest entities responsible for funding menstrual pain research. So it's important to acknowledge the importance of medical research, and particularly women's health research.
Hello there. It's so nice to have you with us, Dr. Hellman. How are you?
Wonderful. It's great to be here.
Thank you so much for that important research. I thought it might be helpful to give our community some context. I had the pleasure of speaking with you late in 2021. And when you showed me what you just showed on the screen in terms of mapping in real time menstrual cramping and pain, it was just, I just knew that we had to bring this information to the community as soon as possible. So thank you so much for presenting it. It really is a huge revelation because of the stigmas around period pain. To have you quantify it in the way that you have. And so we have a lot of questions for you, and there's tremendous interest. I think I'll start with, can you delve a little bit more into the peristalsis, the change of the signal activity as it relates to the uterus? Because I found that fascinating, and a lot of the questions relate to that.
Absolutely. So, first of all, there's a lot of prior work that has looked at uterine contractility, and occasionally they have mixed up peristalsis with contractility. As a result, some of the early literature is harder to interpret. So, if you read older papers, you won't necessarily know whether they're talking about a uterine contraction or just natural normal movement of the uterus. Sometimes people will look at the directionality because you can imagine if there's fluid in the uterus and it is coming out of the cervix or
Mhm.
basically being forced out the fallopian tubes could have very different effects in terms of pain or in terms of fertility. Um, so we're just at a very basic fundamental level now, just trying to see, hey, when a person has a uterine event, whether it's short or long, are they in pain or not? Most of the prior literature didn't necessarily link the pain report to these things that we think are uterine contractions. So, a first step, which is what we have done and published, is say, guess what? There are these uterine contractions, and in some people, we see these contractions at the very beginning of the contraction, it lines up with the pain, and sometimes it's delayed, and sometimes it's in the middle. The one thing we know for sure, aside from what we see in MRI, is unfortunately a lot of women are not getting adequate pain relief. And we think spending more time maybe trying to figure out what type of pain a woman has. This is very basic research, just trying to figure out, hey, are there different types of menstrual pain? To some extent, you know, it's a real revolution right now. Women are starting to really talk about their pains, and it's very clear. Every woman has a subtle difference in terms of the location, duration, frequency. There might be many different types of menstrual pain. So, a first pass is to figure out, hey, um, are you a type of woman that has a contraction or doesn't have a contraction? Is the pain at the beginning, the middle, or the end? And does it make a difference in terms of the therapeutic response? We might discover one day that there is a way to block these contractions, or there might be a way to block the the changes in oxygenation that cause the pain. So this is very basic research, and at this time, it's not a clinically used tool, it's just a research tool. But we're hoping in the future we might be able to subcategorize women by their type of contractile pain, whether they would respond to one medication or not. But what's really important, at least from our level of research, is to some extent, it sounds silly to say this, but it's not in women's head. This is a real thing. there's a prior literature that almost would seem to suggest that it is a psychosomatic event. And if they just wish it, it will go away. Or they undergo some kind of psychotherapy, it will disappear. No, this is something real. We see it in their uterus, and some people it's very severe. And it's not just in their head. We can see it in their uterus. So
And
I hope
it's
I answered that question.
you did absolutely, and you would hope that we wouldn't even have to have this conversation about it being a real thing, but it absolutely is, and I appreciate and look forward to the ways that you're going to build on this current body of work because we really need to see that. Um, I have so many thoughts, but one of them that came to mind while you were presenting was I've often described the cramps that I had as contractions, like on day one, like halfway into day one through day two, from the age of like 11, 12, when I started periods. My friends and I, very dear friends to this day, would be in high school passing around 500 and 600 milligrams of ibuprofen because the cramps were that bad. Um, and I had never heard anyone else in the medical arena describe the cramping as like a contraction, and it absolutely is. What is the pain? Is there a pain scale that indicates that it's like a contraction in terms of intensity? Just how did you come to start using that particular terminology?
Right. So to start off on just a general scale, that to some extent these pain scales 0 through 10, they can be very arbitrary. One person's 8 could be another person's 5. But we generally study women that would rate their menstrual pain 6 or higher on a 0 through 10 scale, just as some reference point that it's bothersome. It's bothersome to the point that they might miss school or work 1, 2, 3, sometimes 4 or 5 days a month. So you have to have some reference point. It becomes very hard to compare one person's pain to another. So that to some extent, the absolute amount of pain, it's just a tool to sort people out. Well, saying, well, if your pain is less than a 5, then it's probably maybe not going to cause you to miss school or work. It could be very disruptive, but we're out to find the people where it disrupts their life the most. Now, in terms of calling it a contraction, it's very hard to definitively say what's a contraction versus what's not unless you actually record pressure. So, in earlier studies, they would put a catheter inside the uterus. They would pass it through the cervix. Now the problem is using a pressure catheter could elicit contractions. So you can't be sure to what extent that occurs in the natural state. What makes me think that this is contractions and not just peristalsis is the endometrial cavity actually narrows. So there's a lessening of the space or the volume where the endometrial fluid is during these contractile events. And it is progressive, and it mimics what you see during um, uh, labor as well as during pregnancy, known as the Braxton Hicks contractions that precede the labor process.
Mhm.
So this bears a lot of similarity to what you see in pregnant women and the endometrial cavity narrowing. And it's worth noting that in animal studies, you can um, study the actual pressure, but again, you would need to do something invasive. And the problem is introducing something invasive to actually measure the pressure could in itself cause pain. And I'll point out the people that have measured pressure, it's exceeded 200 millimeters mercury, right? So just for reference, you know, if you think about blood pressure, certainly exceeding 150 millimeters mercury would be high. Well, if the pressure of the uterus exceeds even the systolic blood pressure, that means you don't have enough blood pressure, enough pressure in the bloodstream to even get to the inner layers of the uterus. So the pressure is important, but it's not something we measure. Our patients are in a lot of discomfort already from their menstrual pain, and the thought of introducing a catheter would definitely scare a lot of people off. But it resembles what we see during a contraction. It resembles what occurs during pregnancy. And it's an interesting question which we don't know the answer yet. If we were to come up with some way of blocking contractility, maybe we could reduce pain in these women. I don't know the answer to that, but that's something I would love to figure out.
No, I greatly appreciate those insights. And for our clinicians listening, I just wanted to expand on your comments around um, a scale of trying to assess a contraction because, as I mentioned, and I think it's worthwhile to mention it again, as a youngster just coming through puberty, my cramps would hit a crescendo of pain in day one and then subside every few minutes. So it was like a contraction and it was destabilizing, like, or immobilizing. I just, couldn't move. It would be in agony. It would cause lots of reactions throughout the body. And someone wrote in and asked for someone without a uterus, how do you explain or convey what this pain is like? And I would love to hear that answer from our community. The thought that came to mind for me was a pinched nerve, but it's more than that because, Kevin, it ties into another thing that you mentioned, which was the gastroenterological impact that can coexist with the cramp itself. And I know that, just I think going back to the pain issue again, I would add to the pinched nerve, just that it radiates throughout the body. Like a pinched nerve is sometimes kind of localized or up and down that one nerve, but then the intense cramping radiates throughout the abdomen, down the legs. And I've explained this to um, some really thought leaders in fibroid research who weren't aware of this at medical conferences before, and the gastroenterological component was something that I experienced at the start of every period. So I'm wondering if that is hormonal rather than the gases building up in the abdomen. And I just kind of parked that there for conversations that I hope we'll continue to be able to have. But um, how do you think we can convey your important research to your fellow clinicians and providers to help them to have a greater appreciation for what women and menstruators are enduring on a consistent basis?
I don't know whether I know the answer to that question, but at least to the audience and maybe to some of the clinicians, to some extent, it's worth noting that some people think menstrual pain is normal. There are people, the audience might be also surprised. There are people that have never had a headache in their entire life. They don't know what a headache is. Admittedly, that's pretty rare. The difference is that roughly 1 in 3 or 1 in 4 women do not have any menstrual pain at all. So to some women, the concept of menstrual pain is completely foreign to them. So, and even among the people that have menstrual pain, there's such a range in the severity. So I think the first thing to appreciate as at a patient level, a personal level, and certainly at a clinical level, is that not all patients have the same level of pain, and it's very hard to evaluate the severity of pain because even a patient that has severe pain might just assume that it's normal. So I think the first thing to do is, yeah, to ask the question, how bad is your menstrual pain? You could do it on a 0 through 10 scale. You can ask, have you ever missed work? Is it a problem? And what are you doing about it? And the reason why it makes such a potential difference is our work, as well as others, suggest that it is a risk factor for other chronic pelvic pain as well as chronic pain conditions, which would suggest there's just some research, there's not large clinical studies on it, but the small studies suggest that if you treat the menstrual pain, it will prevent or reverse the development of other chronic pelvic pains. It might be worth saying that it's also true the other way around. Like if you treat the irritable bowel syndrome, it might help the menstrual pain. And I think everybody wants to have less pain. It's but the problem is it's just become just so accepted that it's normal, and because maybe I don't have severe menstrual pain, maybe the other person is just overstating the condition. And the reality is it should be evaluated, and if people are concerned, they should bring it up with their OB-GYN and try. Your average a gynecologist should have some first line or second line options. And if they don't work, they should consult another specialist that deals with pelvic pain. And um, even if you can't completely eradicate the pain, even if you can reduce the pain, it might reduce the risk for other chronic pelvic pain. Because once you start to have pain throughout the entire month, it can be very disruptive.
Absolutely. And I think our audience is going to find that response and answer very helpful. Uh, we had a question on naproxen and NSAIDs. Is there any danger to taking them every day?
Absolutely. There are risks, side effects, everything from ulcer to increased risk of having a heart attack or a stroke. Um, and, uh, I'm certainly not advocating it, taking it every day. So, one of the interesting questions that we have very little data on, but it's something that gynecologists recommend, is taking the naproxen before the period starts or before the pain begins. So anecdotally, people say that it helps, but there needs to be more research to figure out the right dosage, the right timing, and it's possible we might be able to come up with some topical methods or methods of administering naproxen that avoid the gastrointestinal tract to reduce risk in the future. But it's definitely worth considering the risks, because there are risks associated not just with naproxen, but also with Advil. And it's also worth pointing out that acetaminophen, also known as Tylenol, is also can help many women. However, you do have to worry about overdose, because the profile of effectiveness is limited, and if a person takes too much acetaminophen, it's associated with liver toxicity. So a person needs to balance out these over-the-counter medications. Even though they're over-the-counter, I certainly recommend talking to your gynecologist about them and to make sure you're taking the right dose. A lot of women do not know what the right dose is or the right frequency, and very often physicians will prescribe a larger dose. So there's an over-the-counter dose, and some physicians will recommend taking a larger dose, and that can be prescribed. And for some people, it is necessary to manage their pain.
I'm intrigued by the idea of taking medication prior to your period starting, because that's become a protocol with some surgeries and has been beneficial to the outcomes and to shaking off, if you will, the anesthesia post surgery a little bit more quickly. So that's really an interesting topic to delve in moving forward. I'm curious to know, in terms of the MRI scan, is that the most comprehensive way to conduct your analysis for mapping this pain, or are there other study methodologies or imaging methodologies that you're interested in?
Yeah, we've used ultrasound, and to some extent, it's a wonderful tool. The nice thing about MRI is there are sequences that you can run that allow you to specifically look at oxygen or metabolites such as lactate, which would indicate that there's um, anaerobic respiration. In other words, that there's a lack of oxygen in the system, and it produces molecules that show that there's not enough oxygen in the system, and you can detect it with MRI. The nice thing about MRI is it's also the way it's done, typically used, is it's not user dependent. You don't have a person holding a transducer in place the whole time. Um, there are definite advantages to MRI. We also look at brain activity with EEG. We're looking at nerve activity as well. So I would say I would welcome many other scientists to the field and to use their own modalities. I don't think MRI is. I should be the only researcher using MRI. I would encourage anyone that has an imaging method, and it's not just menstrual pain; it's definitely fibroids. We need more tools. Um, Dr. Segars pointed out before that women are waiting, up to 5 years to get diagnosed. So we need
Yeah.
to have better imaging tools, and I think ultrasound is great because it's very commonly available, and the decreased costs of that device should. I would love to see it in everybody's offices and everybody getting diagnosed with fibroids immediately. And so we could identify these people at risk. And I think the same thing could happen with menstrual pain. I think MRI would be a great tool. We've used ultrasound, and it might be possible for us to go back to ultrasound when we want to make these tools available for in-office use.
That's interesting. I'm also really pleased that you mentioned the cervix, and I don't think there's enough emphasis at times put on the cervix and how sensitive it is, and how the opening and closing of the cervix can be have such an impact on the person and her body, and just how she feels overall. And it made me recall that a lot of times um, I didn't have pain with the heavy menstrual bleeding. No pain really past the initial day while the cervix was opening. And clots passing through the cervix probably were the most uncomfortable thing that I experienced. And um, it's an overall sick feeling more than pain when that cervix is dilating and the huge clots are passing. And I know this is information but again, I'm just sharing that for our listeners today, that hopefully it will help them in treating their patients and having a greater level of understanding as to what they are experiencing. Um, our viewers are really, really curious about pain management and how they can participate in your study. Would you share something on how our listeners can contact you and your team to be able to participate in the study?
Sure, absolutely. So, um, our I would say I would encourage people not just to participate in my own research. I'll give you the information for my own research, but there are some really other great scientists out there also studying menstrual pain, and to look at the opportunities at their own local medical center. Um, a good mark of quality of research, you'll often see it's funded by NIH or the NICHD in particular. So if you see federally supported medical research for menstrual pain, fibroid research, it's a good sign that it's been peer reviewed and it's valuable. So I would encourage people not just to participate in my own research studies, but to seek those locally. So my own website is pretty easy to remember because it's our main goal, cure-pain.org. You can just Google my name and our website should come up, but cure-pain.org. And what I would say is, back to the pain management. I don't make any promises or claims to help people with their pain, at least in the short term. Our goal is really to figure out what when a person is having pain, where is it coming from? And this is a very basic tool, and we use over-the-counter medications like naproxen. And our thought is, if we could figure out even just how naproxen works, um, and the people where it helps and where it doesn't help. And we specifically also do bring in people that have fibroids because they represent, it might be there's something unique about their menstrual pain. So people should seek a gynecologist that understands their pain, and if not, find one that does. And yeah, I'd be delighted for anyone to participate in our research studies. Particularly, women with fibroids are a key area where we'd really like to address their menstrual pain because it is more severe than the general population.
Well, thank you for that clarification. I mean, we are focused on uterine fibroids and diagnoses of the uterus. However, the stigma around the diagnosis is just as overwhelming in a societal context, and has been for generations. And so, your work in really quantifying that pain, I think, is making it a much more tangible concept for society at large. And that's why I see your research is so incredibly important. Um, my last question is, where would you like to take your research from this point?
I want to eradicate menstrual pain. I'd like to really address fibroids and the symptoms of people that have with fibroids, and point out the heavy bleeding and the pain all often overlap. So I think once we have a better understanding of the mechanisms, we'll be able to build better treatments. So right now we're at a stage where we're trying to figure out what's the difference between one person's cramping pain and another person's cramping pain. And if it's contractility, then we'll try drugs that affect contractility. If it is because they're not absorbing the naproxen, then we'll figure out another way to get them the drug that blocks the prostaglandin. Prostaglandin is the product that naproxen inhibits, right? It inhibits cyclooxygenase 2, which produces this inflammatory molecule. And if that is the cause of their menstrual pain, we've got to figure out a way to block prostaglandin production via another method. So my hope is better understanding of the mechanisms, and then maybe 2, 3 years we'll be working on the next round of treatments, and I really hope they work.
Thank you, Dr. Hellman. I so appreciate all that you and your team are working on, and we'll be bringing back updates to our community. Thank you.
Thank you.
It is my pleasure to introduce Dr. James Spies. Dr. Spies is a member of our medical advisory board, and he is also the professor and chair in the Department of Radiology at Medstar Georgetown University in Washington, D.C. After attending Georgetown University School of Medicine, Dr. Spies completed a radiology residency at the University of California, San Francisco, and a fellowship at New York University School of Medicine in vascular and interventional radiology. He has also received a Master's of Public Health from Johns Hopkins University. Dr. Spies served in the Air Force and after military service was in private practice for quite some time, anchoring the Department of Radiology at Georgetown University since 2005. He has an active practice in uterine artery embolization for fibroids and has performed extensive research in the procedure. He is recognized as an international authority on the procedure and has published more than 100 scientific studies and given over 300 invited presentations. Dr. Spies is a fellow of the Society of Interventional Radiology and the American College of Radiology, and has also been named a Distinguished Fellow of the Cardiovascular and Interventional Radiology Society of Europe and Honorary Fellow of the British Society of Interventional Radiology. And I wanted to also share this quote from Dr. Spies, which I think will resonate with many of you. Dr. Spies says, I believe in a collaborative approach to patient care, actively involving the patient and the patient's other physicians. I believe that a well-informed patient is best able to participate in that process, and I strive to ensure that patients have the information they need to choose the medical approach best suited to them. With that, Dr. James Spies.
So I'd like to thank the Fibroid Foundation for inviting me to participate in this summit. I'm James Spies. I'm a professor and chair of radiology at Medstar Georgetown University Hospital in Washington, D.C. I've been involved in fibroid research and specifically fibroid embolization for the past 20 plus years. And so I'm really very pleased to be able to share this with you today. And the question we're going to be discussing is what should the role of uterine fibroid embolization be in the treatment of uterine fibroids? So just to give you a little overview, we're going to talk a little bit about the procedure itself, about some of the technical aspects, just to give those who are not familiar with it at least an idea what's involved with the procedure. And then we'll give an evidence update from the outcomes. That there are several key studies that I think it's important at least to understand. And then talk a little bit about patient assessment and patient counseling. So for those who don't know, and these images are sort of a graphical display of how this is done. This is a minimally invasive procedure. And the goal of fibroid embolization is not to remove the fibroids, but it is to essentially kill them and cause them to shrivel up and turn to scars. And that results in control of symptoms in most cases. And the way this is done, it can be done from the femoral artery, which you can see here on the left, right in the middle of the upper part of the leg, which is typically where I perform the procedure from, or from the arm. You'll see some centers that are doing it that way. But regardless, what happens is the patient is sedated and the area of the skin is numbed up at the top of the leg, and then a needle is advanced into the artery, and then through that, a very thin tube is advanced using X-ray guidance over into the opposite uterine artery. In our center, we actually put a second catheter in and do both at the same time, but there are different technical ways of handling that. The key to this procedure, though, is seen over here on the right, and you'll notice that there are these small beads, and there are a number of different types of beads. Polyvinyl alcohol is one of the types. Acrylic beads, there are a number of different biocompatible, essentially what they are plugs. And those are injected at the base of the uterus, and they are carried out to the fibroids by the flow in the blood vessels. So this is a flow-driven procedure. And because fibroids have these very large vessels with high flow, when you put the beads in, the beads go to the fibroids first, and these smaller normal branches are generally spared. So to give you more of a real life idea what that looks like, we can see here, this is a bilateral or two-sided uterine embolization procedure before embolization. And so this is the left uterine artery. This is if we're looking at the patient, and this is the right uterine artery. And we're injecting, you can see all these abnormal blood vessels in here, and these are feeding fibroids within the uterus. This is how it looks after the embolization, about 20 or 25 minutes later, and you can see that these arteries are still open. If one were to watch it under live X-ray, you'd be able to see this very slow flow, but all those branches that are abnormal are blocked. These down here are normal branches. You can see they're much smaller and sort of more smudgy looking, whereas these are very irregular. And that results in the death, or the medical term is infarction of the fibroids. Now, this image here on the left, you'll see is a woman with a very large uterus. This is actually above her navel. There's the navel. If your uterus goes up to the level of the navel due to enlargement, it's at the equivalent of a 20-week or 5-month pregnancy. And this is a little above that, so it's probably 22 weeks or so. And that's the enlargement of the uterus is due to fibroid. This is a large fibroid right here. There's one here, 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 here. You can see that there are many fibroids present here. This is what this looks like 3 months later. Now notice that the navel's there, and that goes across to this vertebral body. Well, that vertebral body is this one up here. And already we've had the uterus shrink way down into the pelvis. And you can see progressively over time that it will continue to shrink. The uterus over here is probably a third or a quarter of this size or volume of what it was initially. This patient's symptoms went away 3 months, within 3 months after the procedure. But there is progressive shrinkage of the fibroid scars. These are no longer really living fibroids. They are scars. They will not cause any problems for the patient in almost all cases. This actually can occur naturally on its own. So this is a process that is well understood and results in a good long-term symptom control. This is just a different patient, a large fibroid centrally within the uterus, and you can see the progressive shrinkage. In this particular case, essentially all the fibroid has gone by 2 years. There's a little nub left, and at 3 and 4 years. That is not the typical circumstance in which the fibroids disappear, but certainly fibroids can disappear completely, either because the material is passed by the uterus out, or that it shrinks down to just a undetectable scar. So that's the procedure. Just to talk a little bit about it in terms of what it's like to experience it. Well, it's typically done as an outpatient or overnight single night stay in the hospital. There's moderately intense pain for several hours after the procedure, which is controlled with medications. And that's as the fibroids are dying. But by the next day, most women will have, mostly just menstrual cramping for a few days, and a typical recovery is 7 to 10 days. There's nearly no scar. There's a tiny nick, maybe 1/8 of an inch wide at the entry site, but you really can't see a scar on the outside. And most patients can return to work in 7 to 10 days after the procedure. So this is a truly minimally invasive approach. And it is fundamentally different than a surgical approach, which is really, those are directed towards removing fibroids or removing the uterus itself. So let's talk a little bit about how well this fares compared to standard therapies. And if one were to look at the symptom control and quality of life after treatment, there are a number of very key studies, and I'll go through each of these, that compare uterine embolization to surgery. In this particular case, this was done in the United Kingdom. Most of these surgery patients were hysterectomy patients. The EMI trial, which was done in the Netherlands, was uterine embolization versus hysterectomy. And then the FEM trial, which is a more recent publication of a couple of years ago, embolization versus myomectomy. Now, for those who don't know, myomectomy is the surgical removal of fibroids. Hysterectomy is the surgical removal of the entire uterus, including any fibroids that may be present. So those are the two fundamental differences there. These are randomized trials, which are very important in medical research, as they are the most unbiased outcomes that we can obtain. Then there is one randomized study looking specifically at fertility, which we will talk about. So if you begin with the REST trial, as I said, it's a multi-center study that was done in the United Kingdom. It compared 106 uterine embolization patients to 51 surgery patients. And if one looks at the 5-year outcomes from this, you'll see that the symptom and quality of life outcomes are very similar between the two groups. However, you are more likely to require re-intervention, either a repeat procedure or some other intervention with the embolization. That was 26% of cases at 5 years by uterine embolization, and it was 0% for surgery. This is one of the key things that the re-intervention rate for any procedure, whether it's myomectomy or embolization, in which the uterus is preserved in place, can result in recurrence, whereas with hysterectomy, you cannot have recurrence of fibroids, and therefore the recurrence rate is bound to be lower. If one looks at the EMI trial, which was in the Netherlands, again, equal randomization of this group of patients, similar outcomes for symptom control at 2 years, 5-year outcomes, no difference in quality of life score between the two groups. Again, uterine embolization had a higher re-intervention rate. By 5 years, 28% of patients had chosen to undergo hysterectomy, either because of inadequate control of symptoms or recurrence of symptoms, or perhaps for another cause. However, in this study, it's interesting to note that 10% of the hysterectomy patients needed another surgery. And that could have been for bladder problems, or it could have been for scar tissue, a number of other issues. But it does mean, or at least it reminds us all, that hysterectomy still can require additional surgery. It's just that you cannot get new fibroids if you have a hysterectomy. The FEM trial was a recent very important trial because it looked specifically at myomectomy. And myomectomy is often the primary surgical alternative to hysterectomy, but there's been less study over the years, and many fewer myomectomies are done compared to hysterectomies overall. Typically, myomectomy is also done in a younger population, particularly those that are interested in future fertility. So this is a rather large study by these standards. 254 women were randomized between these two procedures. At 2 years, the quality of life was slightly better with myomectomy, but it was within the same range of clinical outcomes. And by that, I mean that there was a statistically slight advantage of myomectomy, but in terms of actual patients being able to tell a difference, there really was no difference between these two groups. Both were very effective at controlling symptoms. The complication rates were similar between uterine embolization and myomectomy. It's interesting in this group, and it was only a 2-year study, 9 women with fibroid embolization and 5 with myomectomy had a pregnancy in that interval. And so that's one of the concerns that often comes up regarding embolization. There's sort of a myth out there that you cannot become pregnant after this procedure. And that, in fact, is not true. And that's demonstrated here in this trial. And in fact, if a patient does not wish to become pregnant after embolization, they need to use birth control, because certainly it is possible. And we've seen that in our practice many times. Hormonal levels also between these two groups were not different. And by that, I mean that there's been a concern about embolization, whether that might have an adverse effect on hormone levels. In this particular study, there was no difference. What about long-term, very long-term outcome? And we do have a couple of trials that have gone out to 10 years. So the Emmy trial, which I mentioned earlier, did have a 10-year evaluation. And after a successful uterine embolization procedure, a total of 35% of women had had a hysterectomy within 10 years after their initial embolization. This could be, again, from recurrence of new fibroids or other causes. Typically, recurrence would be the reason. There is no difference between the quality of life in the two groups, and the satisfaction was also equal between the two groups, even though some women that had an embolization had to subsequently, or chose to subsequently, undergo hysterectomy. There was a different study, a German study, 380 patients, in which they looked at the long-term outcome of embolization patients. And they had a cumulative recurrence rate. And what that means that in total, using the statistical methods, that they found about 24% of women had recurrence by 10 years. They noted that it was a higher likelihood in women under the age of 40, which of course is not surprising, because women who have continued to have menstrual cycles can continue to grow fibroids because it's a hormonally driven process. So younger women who have an intervention are more likely to recur than older women, because once you're in menopause, you do not get new fibroids. Normal quality of life in those who did not recur. So those who did not have recurrence among this group, so about 75% of women were essentially normal compared to women without fibroids. And they also noted that the median age of menopause was 51, which is the median for the entire population. So we were not seeing in this group any early evidence of early menopause after embolization. By way of comparison, there was a large study of 600 women looking at myomectomy and the recurrence rate after that. This was a number of years back from a health maintenance organization in Seattle. 628 women, and 21% of women had a second surgery within this interval, which was basically cumulative incidence of 23% at 5 years and 30% at 7 years. Now, if you think about it, we had, if we go back up here a second, we had a cumulative recurrence rate in this study of 23%, 35% here at 10 years, and here it's estimated to be 30% at 7 years. So just about the same with myomectomy. So what I tend to counsel patients is that both myomectomy and embolization have a chance of recurrence, more likely if you are younger than if you are older, and it is not significantly different between the two procedures. What about reproductive outcomes? Well, we have less evidence on this, and this is more of a concern because this is a key question for patients, but it's very difficult to do these studies. And really, there's only been one randomized trial that has reported their reproductive outcomes over time. There have been quite a number of studies looking at reproductive outcomes and just as a group of patients, but not in a randomized study like this. So in this particular trial, 121 women who had an average age of about 32 had either embolization or myomectomy, and they only had one report of 2-year fertility outcomes. And of course, that's pretty early because many of these patients might have gotten pregnant 3, 4, 5, 6 years later, but that's not included in this study. And so in this, about 50% of women were able to become pregnant after embolization. This is within a 2-year interval. But 78% of women became pregnant in the myomectomy group. Now, there were some technical things here. Some of the uterine embolization patients, actually about a third of them actually went on to myomectomy as part of the protocol. So the numbers here are a little bit muddled because there was less, because of the way the study was structured, there was less opportunity or less time for women with uterine embolization to actually get pregnant in this study. The delivery rate, though, was lower, although some of these, the delivery rate is a little misleading because some of these patients at the end of the study were still pregnant, but it was 48% for myomectomy and 19% for embolization. Now, the miscarriage rate is different. There were more miscarriages in the embolization rate group than in the myomectomy group. So this one study did show that there was a greater likelihood of having a successful pregnancy after myomectomy. Now, the trouble is, as I indicated, there are a number of flaws. And when this was evaluated by the Cochrane collaboration, which is an international group that assesses the quality of evidence in healthcare, they said that there was weak evidence favoring myomectomy over embolization for women who specifically are trying to get pregnant. It isn't as if you cannot get pregnant after embolization, but you are slightly more likely, at least there's some suggestion of the evidence of getting pregnant after a myomectomy. And unfortunately, that's about the extent of the high quality evidence that we have. So when I talk to patients about this, I summarize it as follows. If you, regarding fertility, first, the patient should try to get pregnant without any intervention. Women regularly get pregnant with fibroids or able to carry to term. Now, there can be a more complicated pregnancy with fibroids, and sometimes it impacts the ability to get pregnant. But one should not assume that you need to have something done, some surgical procedure done before you attempt to get pregnant. Occasionally, that may be necessary, and that, you know, under the guidance of a reproductive endocrinologist or a gynecologist specializing in this area. But women should not worry about requiring a myomectomy before trying to get pregnant. The second thing is if a patient has symptomatic fibroids, we typically recommend myomectomy if it is feasible as the first choice for those seeking pregnancy. And it's based on that one study that I just showed you. So there's a slight advantage, we believe, in myomectomy. We don't know for sure, but given we're going to give patients the benefit of the doubt on that one. But there's no question uterine embolization still has a role. So number one, in patients who already have had a myomectomy, a second myomectomy often will result in very poor reproductive outcomes. And so the likelihood of getting pregnant after a second myomectomy is significantly lower than after a first because there's a lot of scar tissue within the uterus and the distortion of the uterus may be greater. So for those patients, uterine embolization may be a preferred procedure. There are patients that are poor surgical risks, you know, because of other medical conditions they have or other kinds of issues, the extent of the fibroids, et cetera. There are some fibroids that are very difficult to remove surgically. And so one can't assume that myomectomy is always going to be better because on occasion, in trying to get out a very difficult to remove fibroid, a patient may end up requiring a hysterectomy. So that can occur. And then finally, there's patient choice. And so, you know, there are many women who can be presented with this information and say, well, we think there's a slight advantage to myomectomy. They say, well, that's fine, but I don't want that. I don't want to go through that procedure. I'd rather have an embolization. The key is that the patient needs to have a proper informed discussion prior to giving or making their treatment decision and consenting. So that's an important part. Whenever we see a patient's interested in pregnancy, it's a more extended discussion than typical. What about complications after embolization? Well, this is a summary of two large studies that were done years ago And these are probably still the two best complication studies, but there are others out there, and they all show similar results. So there is a syndrome of sort of fatigue, malaise, sort of loss of appetite, sometimes some nausea, occasionally a mild fever that occurs after any surgical procedure and specifically occurs after embolization. This is called post-embolization syndrome, and it is normal. It's a normal part of recovery. However, occasionally patients will get high fevers or will have significant uncontrolled pain that is atypical or not usual, and that might require readmission. So we would consider that an adverse event. And that's around a 2 to 5% frequency, depending on the study you look at. A patient can transition into menopause as a direct result of embolization. Now, this is not common. For women that are 40, it's probably a 1% or less chance. At age 45, it's in the range of about 5%. And it's 7 to 10% by the age of 50. So it depends upon your age. And the reason it varies with age is because the amount of ovarian function left as a woman ages through her 40s diminishes, goes down progressively. And once you're at the very edge of menopause, having a procedure that can slightly alter the blood supply in the pelvis can transition a woman into menopause. But for a younger woman, particularly a woman trying to in prime reproductive age of in the 30s or early 40s, it's very rare. Occasionally, fibroids can be expelled, and that can result in vaginal discharge, infection, actually tissue passage. Despite what you may hear from some, because this can be a very unpleasant circumstance, and we definitely look for this and we try to manage this actively, and we try to counsel patients that may be prone to this particular complication. It is infrequent. It is less than 5% in most studies that have been done. There are certain patients that are at high risk and certainly could have a 10, 20% chance of this occurring, but for the total population of patients is fairly infrequent. Still, that or an injury to the uterus or some infection or some problem could arise that would lead to the need for a hysterectomy, despite our trying to avoid it. And that's about a 1 in 200 chance. Blood clots can form after any medical procedure. They occur about 1 in 400 after embolization. There's about half the rate of what it would be with surgery. Surgery is around 1 in 200. So there is a chance here, but certainly there is with the alternative procedures as well. Then it's always possible to damage the artery where we go in, for there are some other pelvic structure to be damaged by beads going in the wrong direction, injury of a vessel, during the passage of the catheters. This is very rare. It's about 1 in 1,000, and really, in over 20 years, I've only seen a few patients with these kinds of issues. Finally, there's always a chance of some catastrophic event occurring. Extremely rare here, and again, this is likely in this particular procedure related to blood clots in some patients that aren't properly managed or infections that aren't properly controlled. But this is very low, and it is less than it would be for a general surgical procedure. So this summarizes the most recent guidance of the American Congress of Obstetrician Gynecologists, and that is they conclude that based on both the short and long-term outcomes, this is a safe and effective option for patients with symptomatic fibroids who wish to avoid losing their uterus. So this is essentially an endorsement of this procedure, and that it is a proved procedure. This is not controversial. This isn't experimental. This has been around for well over 20 years now. So having said that, who do we treat? Well, first of all, we only treat patients that are symptomatic. And the most common symptom, probably 80% of patients that we see have heavy menstrual bleeding, can be associated with anemia, painful menstrual cramps, back pain, pelvic pain around the time of a patient's cycle. Pressure or heaviness is common, particularly as the uterus gets larger and larger, and bloating. And this, of course, is usually worse around the time of the menstrual cycle. Urinary frequency, urgency, painful intercourse, rectal pain, pressure can be caused by fibroids depending upon their location. And there can be interference with reproductive attempts. That's a more complicated discussion than we have time for today. So what about fibroids? Well, they typically cause symptoms based on their location, and the ones that distort or bend the lining of the uterus, ones like this, that are very large, or ones like this or like this, will cause heavy menstrual bleeding. though the total bulk of the fibroids is what typically causes patients to have the pressure discomfort, and pain, of course, can be related to the specific location of one fibroid. So when we advise patients, what are the key questions that we want to address? Well, first of all, we want to know, does the patient want to avoid losing her uterus? And that's may seem kind of a silly question, but there are women who absolutely do not, and there are women who do not really care one way or the other. And so that's an important thing for patients to decide. Does the patient wish to have the most durable treatments? In other words, they say, I've got fibroids, I'm done with my children, I don't want to ever deal with this again. Well, they may want to consider a hysterectomy, because there's no question that hysterectomy will prevent the recurrence of fibroids. You will not get new fibroids if you have a hysterectomy. Of course, you won't have a uterus either, and there are some potential downsides to that, but that's a key question. Does the patient want the least invasive procedure? And certainly among the major procedures that are being done for this, uterine embolization is the least invasive. Does the patient want to have children in the future? That is a longer discussion, as we've alluded to before. And that is something that, of course, hysterectomy is not an option. And so then we're really discussing myomectomy or embolization in many cases. So who do we treat? Well, as I indicated, we always treat patients that have symptomatic fibroids. We do not treat specifically for fertility reasons alone, but maybe in very rare circumstances. But that's, again, a separate decision typically done with the gynecologist and interventionalist in close discussion with the patients. But most patients with single or multiple fibroids can be treated, and the number of fibroids or their location really is only a relative consideration. There is some evidence that patients that have sort of moderately large or smaller uteruses will do better. So if one were to ask me, I'd say, well, 20 week size. So a uterus up to about the level of the navel will do better than a uterus that's up to the diaphragm, filling up the entire abdomen. But we will treat patients 22, 24 week size, 28 week size. But as you go up, the likelihood of having enough shrinkage to be able to get a flat abdomen and really feel like yourself again, the likelihood of that goes down somewhat. So that's a discussion we tend to have with patients with those super large uteruses. So who are best for uterine embolization? So I indicated you definitely can become pregnant after embolization, but again, the easier decision is if a patient's done with childbearing, then embolization really should be a key consideration. Patients who wish to retain their uterus, obviously, and so really, if you don't want a hysterectomy and you're done with childbearing, we're really looking at embolization versus myomectomy, and the question is, why go through myomectomy when an embolization is an easier recovery? Poor surgical risk patients generally are referred to us for embolization because, again, you can get excellent outcomes and it's much less risky for some of these patients. Patients who've had prior pelvic surgery, which makes them less good surgical candidates because it can be very difficult to do an operation where there's scar tissue around the uterus. So we often will have gynecologists refer patients who've had a prior myomectomy, for example. And those who are wishing to have a minimum recovery time and minimum impact, because this has been shown in those studies I alluded to earlier, they have an easier recovery than surgery. Where will we consider embolization to be the second choice? Well, if a patient is being treated for infertility or has a strong interest in pregnancy, we would again favor myomectomy, again, based on not strong evidence, but at least some evidence suggesting that they may do better with myomectomy. Patients with a strong interest in the most durable treatment, as we said, this would be hysterectomy. And as long as there's no contraindication to that, that certainly is a rational and reasonable approach for the patient who chooses it. And then patients who have only submucosal or what we call intracavitary fibroids, in other words, inside the cavity of the uterus, those often can be removed with a scope in a minimally invasive procedure done as an outpatient, in which they go in through the vagina, into the uterus and remove the fibroid. But if you have multiple fibroids throughout the uterus and maybe one small fibroid in the cavity, probably you're not going to get the symptom control. So when I say only submucosal, I would say maybe primarily submucosal fibroids that are resectable. In other words, they can be removed. We think hysteroscopic resection is best. But for patients that have fibroids throughout the uterus, even if they have an intracavitary fibroid, in many cases, embolization may be a better first step. And there's some nuance to this, which of course we would personalize to every given patient. So sort of based on that, those sort of general rules about how we approach this, how does this sort of shake out in terms of how many of our patients actually will we consider to be embolization patients? So a number of years back, we looked at a 15-month interval of patients we saw here at Georgetown. It's about 500 patients we saw in consultation. And about 2/3 of those, we said, yes, you're an excellent candidate for embolization, but you're also, of course, a candidate for hysterectomy or other things. But in other words, uterine embolization was recommended as, the primary, one of the primary choices. In other words, you're a good candidate, but it's up to you, the patient. There were 161 patients, or about 1/3, that we recommended something other than uterine embolization as our primary choice. So 51, we recommend hysterectomy. Well, why would we do that? Super large uterus or fibroids that would not respond well. And there are a few subtypes of fibroids that do not respond well to embolization. They're quite unusual. Patients who have suspicious looking fibroids that might be malignant or may be a more aggressive form really ought to have surgery. So all those kinds of patients are included there. 41% of 41 patients, we recommended myomectomy. Why? Mostly fertility reasons. The patients said, well, I really want to get pregnant, not to get pregnant the next year or two. Then we recommended myomectomy. There are other procedures that can be done. Some patients had minimal fibroids. They had one tiny fibroids, but the cause for their bleeding or issues were something else. And so we either recommended use of medical therapies or additional evaluation. And again, there are things that can be done conservative. There are patients who are diagnosed with fibroids or are concerned about them, have no symptoms. Well, they don't need to be treated because the vast majority, a substantial number of the patients who have fibroids will never need treatment. And then there are medical managements, either oral contraceptives or certain kinds of hormone releasing intrauterine devices can be used. So there's a range of things that can be done. So a procedure is not always needed, and UFE is not indicated in every single patient. So I would summarize in the following way. First, there's no question uterine embolization has been established as a safe, effective, and durable procedure in the short and midterm, and now really with the 10-year studies, the long term. So there's no question that this is compares favorably with certainly myomectomy. There are 10 times as many hysterectomies as there are uterine embolizations. Each potential patient should be informed, I think, of uterine embolization. This is still one of our great goals. It's just getting the word out there and being sure the gynecologists include this in their discussion with patients and at least consider referring a patient to an interventional radiologist for consultation prior to making a final decision. But there's no question, I would say, that uterine embolization has emerged as the standard among minimally invasive therapies. And therefore, for a patient who would like to avoid surgery, I think this is the best choice for nearly every patient. And with that, I'd like to thank, again, the organizers for including me. And I appreciate so much the opportunity to discuss this procedure with you. And I look forward to the questions that will be coming. Thank you.
Can you hear me?
Now I can.
Okay, great. It's so good to see you. Thanks for being with us today.
I'm really very happy to be here. It's a great event, and yeah, I hope that we'll be able to give more information to patients and answer some of the questions.
Sure. Well, you have a ton of questions here, and I'm going to try to get to as many of them as possible. I wanted to start by first thanking you for giving a comprehensive overview because you answered quite a few of the questions around how to determine whether or not you're a good candidate for UFE. And I wanted to back up a little and ask, what are your thoughts on, from the patient perspective, what questions should we ask or how should we go about finding a really good UFE provider?
Well, first of all, I would ask your gynecologists. They may not think of uterine embolization right off the bat, but many of them, particularly in larger cities or metropolitan areas, will know of someone who they think is a reliable and capable person to do this. So I get many of my referrals, majority of my referrals from gynecologists, and I know many of my colleagues around the country the same. The second thing you could do is go to the Society of Interventional Radiology website, which is SIRWeb, SIRWEB.org. And then enter fibroids. And there's a page there giving information about uterine embolization and a directory to be able to find physicians. That's a very broad group of people, and some do more than others. But I think by at least starting there and looking who's in your region, you should be able to narrow it down and find someone that would be very helpful. And I think resources like your group. I mean, I know that you and many of your members have had personal experience, and I think being able to use patient advocacy groups for discussion, but also recommendations of providers is really very helpful.
And that's a great segue because I will share that you did perform my final fibroid surgery, which was a UFE, and it went incredibly well for many reasons. One was your bedside manner, which I think is coming across very apparently to our community viewing today. And the other thing, which I actually thought was funny, was it being my fourth fibroid surgery. I thought I knew the ropes and that I could just go home. And I really tried to present my case for going home the same day. And you had me stay overnight. And that was the best decision possible because I needed that night of additional support in the hospital to deal with pain management. And it makes me reflect on some of the feedback that our community gets that everyone goes home the same day. And so our first question is, how do you determine whether or not going an outpatient procedure or an overnight stay might be required? Like, what are some of the considerations?
Well, for us, the standard has always been overnight. And I always tell patients, about 1 in 5 is going to have some problem with pain during the middle of the night. And I can never quite figure out the 20% that are going to have that. We have actually changed our pain control protocols in recent years. I know that some of your group may have received, for example, a severe hypogastric nerve block, which is a type of block that can be used, and that will be a good, reliable control of pain. I don't use that myself, but there are other things we do. So I'm a little more liberal on this now. Most outpatient protocols require you to take medications on a set basis, meaning like get home at 8 p.m. and at 10 p.m. take these 2 pills and then wake up at midnight or 1 and take this and go through the night that way. And I've always just felt that it was easier to anticipate problems by having people stay overnight. So my recommendation for everyone in my practice is to stay overnight because it's easy. In fact, I don't think the hospital charges any more for a 23-hour stay than they do for like a 10-hour stay. But it's different in every practice. Many centers are doing this as an outpatient. My own group at the Washington Hospital Center, which is one of our sister hospitals, do it same day admission and discharge. So I don't think there's any golden rule about this, but I feel better if I'm not having a conversation with somebody that's in real significant pain at 2:30 in the morning. And the question is, should they go to the emergency room? And that's just an awful outcome.
I completely agree. And yeah, thank you for explaining that so well because that's one of the most frequent questions that we receive. We have another question here. Is there an ideal age for UFE? I guess reflecting on talking about potential recurrence based on when in your reproductive journey you have fibroids. There was a question on, is there an ideal age range?
Well, there really isn't, although the younger you are, the more the issue of reproduction comes in, and the more likely we are to lean you in the direction of myomectomy, for example. But it gets to be very complicated. I've seen patients who had a myomectomy at age 26 and then are back at age 31. And that's somebody that maybe they should have a myomectomy, but maybe, depending on the fibroids and embolization, would be the way to go. But I would say typically the best age is in the group of women that are older because they are done with child rearing. And embolization really is a question of controlling symptoms. And if you put this head to head against hysterectomy, for most women, we'll get that patient to where they'll be satisfied and pleased and still they'll be able to avoid surgery. So our average age is about 42 or 43. That's skewed a little bit high because we have a tendency to refer patients for myomectomy in their 30s. But as you know, African American women are more likely to get fibroids, but in addition, they're more likely to get them earlier and have them be larger. So therefore, the rules kind of go out, we're outside the bounds of the rules in many patients who might have already had 2 myomectomies by the age of 36 or 37. Embolization clearly is an appropriate approach at that stage for many of those women.
You again answered another question ahead of time because someone asked after multiple myomectomies, could UFE be an option?
Oh,
And
it's absolutely, it probably should be the option, unless you're talking about hysterectomy. And even then, a hysterectomy in a woman who's had two prior myomectomies, abdominal myomectomies, regular operations, there's a lot of scar tissue, and it is not necessarily an easy operation. Whereas embolization generally is no more difficult after surgery than it would be if you've never had surgery.
that's incredibly helpful. Is there a size of uterus or a number of fibroids that determine whether or not UFE will be successful? Like if a uterus is over a certain size, or if there are a certain number, if they have several fibroids, are there other considerations or protocols when considering UFE?
Yes. So in women that have super large uteruses, and I'm talking about, they're up to their entire abdomen is full. It's like they look and feel as if they're at term pregnancy. We generally would recommend surgery, although I'm willing to consider embolization in specific circumstances, and it really depends upon the patient, what prior surgery they have, what are their goals. But if a woman comes in and says, I look like I'm 8 months pregnant and I want to have a flat abdomen again, they're going to do better with surgery, removing those large fibroids. Occasionally, we'll do embolization before they have the surgery, which really makes the surgery easier. So we'll work with the gynecologist, and we likely would do that within the same day of surgery or the day before or something like that. So really, really big uteruses probably lean towards surgery. We did a study years ago that showed that the amount of shrinkage is greater for any given size uterus if you have a bunch of small fibroids versus a big fibroid. However, that is only a relative consideration. So I would not say, I have one big 10 centimeter fibroid, you really ought to have surgery. I would say, generally, my limit is a 15 centimeter fibroid, which is, roughly about 7 inches in diameter or 6.5 or something. That kind of fibroid, I generally am going to lean somebody in the direction of surgery.
That and we have another question about pain management after UFE. I had really successful pain management during after my procedure, but not everyone does. Is there a protocol for that as well?
Well, our adjusted protocol right now is sort of the following. We would like to get away from relying so much on opiates in general. So what we do is we give Decadron, which is an intravenous medication that is like prednisone. It's an anti-inflammatory. It's the ultimate anti-inflammatory. Cortisone, cortisol. So it's a form of that. That's an anti-inflammatory, so we give that to everybody. We now are routinely using Tylenol, which is acetaminophen, regularly afterwards, both in the hospital, either intravenously or orally, and then in recovery. And we're giving anti-inflammatories, specifically something like Motrin in that class of drugs. We give that something like that in the hospital and then when you go home. The combination of those two, plus the anti-inflammatory up front, the Decadron, we believe gives a lower pain profile, probably than you had during your procedure. And then we use a limited number of oxycodone orally afterwards when you go home. And most people may need 3 or 4, maybe 5 in the course of the first few days, but not that much. If you go home the same day, you might need a few more of those because they will definitely be having you take that usually that first night. The pain after this is greatest in the first 18 hours and typically really more in the first 6 to 8 hours. But if you then sleep through the night, some of that pain can come back. So that's why many protocols are at, wake up at midnight, wake up at 4 a.m., whatever, in order to manage that.
And very interesting. So I know that you are an international expert on fibroids. For our community who may not have heard Dr. Spies speak before, he truly is, as one of his colleagues told me, the godfather of UFE,
Wow.
which I thought was funny. I'm curious to know the future of embolization. Is there anything that you can share with us about how the technology might be, the research that might be taking place, how it might be evolving, or the bead technology, how it is evolving or potentially will?
There's, sort of always continued innovation. I just mentioned several regarding pain management afterwards. Um, I also should mention, for example, there was a very nice study a few years ago, and we routinely use an intraarterial anesthetic at the end of the procedure, which has also been shown to reduce pain. So there's a number of different things, sort of incrementally improving things. From a technology perspective, the ongoing search is for a resorbable, and when we say resorbable, we mean an embolic material that does its job, and once the job is done, it dissolves. And so we would like that because there are patients that are concerned. Well, what are those plastic beads doing? They are injected. They go in. They land in the vessel. They get wedged in place. They're scarred into place. They don't go anywhere. But people would prefer not to have them there. We don't know of any adverse, effects of those, and they've been used. One of them's been used for about 40 years. The other one we use for about 20 years. They're very well known. So one that would go away in a matter of weeks would be great. And there are a few out there. The trouble is the ones that are currently available have other technical problems, like shelf life issues or issues related to swelling during the procedure and make them difficult to deliver. There's some bumps in the road in the development of those. But I expect that over the next several years, we will have reliable, effective, resorbable embolics, and then we will be able to use those routinely, which I think would just be an added benefit.
Someone just remarked that they spoke with their healthcare provider to take a more conservative approach to the bead implantation to preserve fertility. Um, are there options to really discuss in more detail how the procedure will actually go patient to patient, or are there any thoughts that you have around that type of collaboration?
Well, yeah, first of all, it's a patient decision. I mean, it's a joint decision.
Mhm.
But I know, for example, with related to the beads and fertility, there's this concept that if you use this material, which is called gel foam, it's been around for 40 years, it's dissolvable. So there's this thought that, well, if you use that, it dissolves, and then the patient will have, their vessels will be normal, everything will be fine, and that'll optimize their ability to get pregnant. The problem is there's some evidence to show that using that material actually is more likely to permanently occlude uterine branches than using the material that we currently use because it causes an intense reaction in the vessel. So the material itself may dissolve away, but the inflammatory reaction in the clot may block the vessel. So even though my colleagues in the field will sometimes discuss that, the evidence to support it is really not there at this stage. But if a patient came in and said, listen, I want a resorbable embolic and I'm willing to accept whatever consequences may be associated with it. I mean, there's no, like medical reason you couldn't use them. It's just that we don't have as good evidence that, that they are as effective, and they're a little bit less predictable in what the eventual outcome will be.
Thank you for sharing that. And I think the number one question we get, which you definitely spoke at length about, is concerns over fertility in UFE. And for those of our listeners who are still have the desire to potentially conceive, and are looking at UFE as an option, what questions should they ask, or what considerations should they make in terms of? And I know it varies greatly, case to case, size of fibroid, size of uterus, but just generally, if you could share some thoughts around
Well,
that.
first of all, just to dispel a couple of misconceptions that patients might hear from a gynecologist, because gynecologists are expert in gynecology, but they're not experts in embolization and the technology and the outcomes necessarily. So first, there are some gynecologists who feel that embolization will make you infertile, and that is rarely, if ever, the case. It can negatively impact the function of the ovaries, just like hysterectomy can. But that is almost always in women that are in their later reproductive life, 45, 48, 50 years old. So in a woman that's, say, 40 or younger, there's no evidence at this stage that that's the case. Two, the uterus itself is rarely damaged. So there's this concept, well, if you block the uterine arteries, you're killing the uterus. That's not the case at all. The beads selectively go to the fibroids. The normal parts of the uterus are spared. So it's not impossible, but it's very rare to damage normal portions of the uterus. So you definitely become pregnant after embolization. I mean, we've probably had 150 pregnancies at Georgetown. Again, most of the women that we do UAE on don't want to have a baby, but some do. Some say they don't, and then the year later say they do. And and I might have recommended myomectomy if they had been in a different frame of mind, but they were able to become pregnant. Now, the studies would suggest the likelihood of getting pregnant after UFE on average are somewhat less than they would be with myomectomy in a woman who has never had fibroid surgery. So my first recommendation, let's take the typical patient. You're between the ages of 30 and 40, or maybe 42, and you want to have a child. I would talk to your gynecologist first to see if you're a candidate for myomectomy. You might even think about talking to a reproductive endocrinologist because they are sort of experts in that area. If you are a candidate for myomectomy and they think there's a reasonable chance you could get pregnant after the procedure and you've not had prior surgery, then I would recommend you can go to have the myomectomy if childbearing is the important thing. It gets more difficult, or the decision is trickier for extensive fibroids that are difficult to remove surgically, prior surgery, a number of other factors. But our first choice with what I've said in the talk was relatively weak, but still some evidence that myomectomy should be considered first.
Is it more challenging to treat, say, a pedunculated fibroid versus a submucosal fibroid? Or
Generally, the treating of it or the procedure is not different. However, a pedunculated fibroid that is big, well, there's a way in the outside of the uterus that sticks off, like, say, a Mickey Mouse ear. Those have a little bit lower likelihood of being successfully treated completely with embolization. Doesn't mean we wouldn't treat them, but I often tell patients, like, well, I'm not sure about that one, and maybe they won't be able to kill 80% of it. I don't know about 100, because they can steal small blood vessels from the side of the pelvis, from the adjacent bowel, from other places that we can't treat. We can only treat from vessels that are feeding the uterus. We can't generally go out and treat these other sort of tiny little, what we call parasitized or stolen blood vessels.
Very, very interesting. That's really helpful. One person asked, what does delivery rate mean?
Delivery rate
Mhm.
is you have a baby, the baby is fine, or well, the baby's alive anyway, and you deliver successfully. So delivery rate is completed pregnancies. Pregnancy rate is you're pregnant. Why would there be a difference? Well, there could be pregnancy loss. And at this end of any study, there's always people that are still pregnant and you no longer are collecting data. So they may go on and have a completed pregnancy delivery. So, you know, and the trouble with that study that I went over was only a 2-year study. So first of all, you had to have women that try to get pregnant within 2 years.
Mhm.
They asked people to wait 6 months after the procedure to try to get pregnant, so that leaves 18 months. And for the UFE patients, a third of them, by the criteria, had remaining fibroids that were of certain size, even though were successfully treated, and they underwent surgery in addition. And they told them to wait another 6 months. So in that study, this is very confusing, but in that study, the uterine embolization women had a shorter period of time to get pregnant and a shorter period of time to deliver.
Okay.
That's one of the problems with the study, is that it is an asymmetric, not equal evaluation.
I
But,
understand.
you know, science is never perfect, and I think people expect it to give clear answers. And what I've learned over the last 30 years is nothing is that clear.
Yeah, this is so true. So, last question, Dr. Spies. We're getting lots of questions on access to UFE in different parts of the world. We have huge followings in the Caribbean, throughout in other continents, Africa, the Middle East. What are some of the challenges that you've seen in having potentially a radiology clinic with, the necessary skill sets to treat fibroids set up in different parts of the world? Is there anything that you'd like to share relative to that, or and any ways that we can help to advocate for that type of access to be more readily available to our community?
Well, different parts of the world. The Middle East actually has a reasonably sophisticated interventional radiology community, Egypt and Saudi Arabia and some others. There are some cultural overlays there that complicate things a little bit, but in general, I mean, I've spoken at the Middle Eastern meeting and it's a sophisticated group, and so it should be available in that region. Again, the barriers might be lack of knowledge on the part of a gynecologist or distance travel or whatever. So it may require people to do a little extra work, maybe get a second opinion, that sort of thing. Sub-Saharan Africa is definitely a problem. But there are places, for example, I'm associated with the American Board of Radiology, and we are working with a group that has been training interventionalists in Tanzania, trying to um, put in place an evaluation process, sort of like a certification for the field in general, and that would include uterine embolization. South Africa does have capable people in the major cities to be able to do this, and some of the other far southern African countries do. There's a wonderful physician from the UK, Nigel Hacking. Just love Nigel. And Nigel is now retired from his practice in the National Health Service. And he has gone out and he goes to Nairobi, he goes to Botswana, he goes to some other different places, and comes in for like 3 days and will treat 30 patients. And so he has a collaboration with a gynecologist. He does the same thing. I'm trying to say if it's Barbados or Trinidad, I'm not sure, but there's a Caribbean site. So unfortunately, like many things in healthcare, there's not equal distribution. But there is an effort among physicians in Europe, the UK, and the US to try to reach out to do more in these settings.
Well, I couldn't think of a better note to end on because that's hopeful. And to the extent that we can, we'll um, try to connect our viewers with Dr. Hacking. And we so appreciate your input today and your insights and being a part of our medical advisory board. We're just very, very grateful. And thank you for being with us today.
Well, it's been a pleasure. So I look forward to future events. Take care.
You too.
Thank you for attending the Fibroid Summit 2022. I am sure that you have learned a lot, and we hope that you will take what you have learned seriously and will continue to advocate for further research in uterine fibroids.
Wow, another great day. Thank you all so very much for attending Fibroid Summit 2022. We appreciate your time, your interest, and your engagement. I'd like to again thank our partners who made this possible, our gold level partners, AbbVie and Myovant Pfizer, and our silver partner, Hologic. This event would not have been possible without their support. We have many more programs in store for you this year, and so we invite you to visit fibroidfoundation.org to register for regular updates on our programs. And I invite you to also visit campionfund.org to see their amazing lineup of programming. Thank you all again. Be well, and we will see you next year.